If you need the chicken bag or anyone like I obviously I have because I always buy return.
I didn't realize I can buy those tickets that cheap. Normally I buy also return tickets for like 20 something. But that's included London travel card as well. And this time, it's last 5 months back. It's 17.
Still sort of waiting for that.
Sunday? Yeah, 8 days now. My jet lag is okay. Still,
Where's this way or
the other way? The other way. This way is much better. Because when I arrive here, it's like an afternoon. Drive home, like 7 o'clock in the evening. Have a dinner, relax, shower, go to bed. It's much better. The other way is like to Beijing, all the night flights. I couldn't sleep so well. And arrive Beijing is like in the morning. You have the whole day.
You cannot sleep.
Sleep probably in bed or nap, but I can't sleep very long hours. I can't sleep that's really bad. For like 3 or 4 days, I feel like drowsy.
Interior saturation.
It's like still, I travel like 3 times each year, back and forth. It's quite tiring. I have no idea. I didn't tell you last week because I came for the second day. Yeah. You tell. Published laws. His name Pierre. Sorry? They have like advanced disease was found called
Because the eyes are.
yeah. His name is Pierre like more than 20 years last week. Just cool. Still that's a lot.
It only tries 2 interior and 2 posterior. Like one answer. Yeah, there are a lot of packages you can use from very large.
What is it? It's like machine learning.
Yeah, I could classify it.
Yeah, that's why I asked.
Well, hello, good afternoon. Welcome to UCL, to the 7th Spinal Cord MRI workshop. It's the second time that we organize this workshop here at UCL. Last year was with another name, but well, Julian will allow to me to say that it's another edition of the same workshop. And basically now I'm going to go for a few slides just to give a little bit of introduction to the workshop. Nothing special, just venues, passwords, etc. These type of things. A little bit bureaucratic, but just to help you a little bit. First of all, the Wi-Fi is the most important, as usual. EduRoam, for the people that in their institution, they already have EduRoam, normally is your email and your personal password of your institution. Otherwise, there is UCL guest where you can choose as user your email, for example, and then generate whatever password you prefer. And the first time they ask for an even code, you need to put this one. Okay, once you have generated this user and password, you can use over 48 hours or 72 hours, okay, for the whole workshop. If it doesn't work, let me know, because last year was a cataclysm and didn't work at all. But I hope that this year works. Then these are the sessions at the moment. 4 sessions. Well, we are a little bit unlucky because Ruth is ill and he's not going to do his presentation. But all the other speakers, I think, that are here at the moment, just waiting one, but nothing else. The only thing that is going to change is that we cancel this presentation, okay? This afternoon, after the coffee break, okay? Then in each session, there are four presentations. Each presentation is 20 minutes. We have plenty of time to do questions. There are 10 minutes of questions where you can ask whatever you want. I mean, with calm, there is no rush. We can ask. And for the people that is presenting, if they want to use their personal computer, we have time to change computers and test the personal computer, okay? Each session, they have 2 chairs that are people from our group in UCL. Mario Zambavna, they are here for the first session. Becky and Marco for the second. Sarah and Marcello for tomorrow morning, and then for the closing session, Francesco and Rosario. What else? First of all, I'm sorry, because almost for each session is a different room, and this is a problem at UCL. We are in lecturing time, then all the rooms are very busy. Then we start here today. Luckily, we are in the same building, but we need to change at 5. I think that we need to go to the 3rd floor, okay, to our lecture theater. Then the dinner is here, okay. I will speak about the dinner later. Tomorrow morning, we are going to do a little bit more tourism through the campus. We go to that building on the top, close to Houston Road. And finally, for the people that is doing the course in Tuesday afternoon, the Spinal Cord Toolbox course is in the Cruciform, just in front the portico. The portico is the building that is giving the logo to the UCL, okay? Then, sorry about that. I couldn't find the same room for the 2 days. Then the dinner, as I sent in the email, the dinner is going to be in the All-Star Lane. It's a light dinner with some drinks, and we are going to be able to play a little bit to bowling, unlimited. And I think that there is a Wii as well to play. It's very close. We are here, okay? Just cross Russell Square, go down, and more or less, where is the Hilton? Just turn on the right, and you are there, okay? Finally, well, the meeting time is half past 7. For the course, very important, and some people approach me just right now. It's tomorrow afternoon, but of course, this is very important. Bring your own computer because we cannot provide computer for everybody. You can use your own data, but please, and this is the most important step, and Julian, you will need to help some people because they asked it already. Install the latest version of the tool because the slides are going to follow the parameters of the latest version. If you have any problem with the installation, maybe on the coffee breaks or tomorrow morning, and you can ask to Julian, and even the The course starts 1 hour later that it was announced. It's going to start at 3 o'clock instead of 2. Then we have a little bit of time to configure all these things. Finally, just to remember to everybody, we have this website where the community is sharing the forum with all the problems using different acquisitions or the different softwares, the protocols that we agreed, and then some softwares and the workshops that we are doing every year. And the host institution is CIMIC. CIMIC is the Center for Medical Imaging, and is my department, or well, where I am working. And basically, it was established in 2005, and we are working in the diagnostic, prognostic, and interventional systems. Not only spinal cord, we work in a lot of disease where, well, this graph is trying to take all of them. And we are a large group, more than 100 people working in medical imaging, different topics. Okay, it's led by Danny Alexander, but today he's lecturing. Then he cannot come. I don't know if Freddy, you want to say anything else? No? Then, well, Danny said, thank you for coming to UCL. And finally, all the companies that are supporting the companies and charities that are supporting the event. Okay, thank you very much. Just give the talk to Emma. Emma is from Spinal Cord. I'm from the society. So.
Oh, thank you. Good afternoon, everyone. It's really lovely to be here. I'm Emma Gray. I'm Head of Clinical Trials at the MS Society. And I was kindly asked to say a few nice, kind words to you all to inspire you for your the day ahead and say how important is your work is. And I know you know that, but I'm going to tell you anyway. And I promise to keep it really brief as well. The MS Society is obviously delighted to have supported this meeting, and I'm personally delighted to have left our office. If you know where our offices are, you'll know why. So this is a treat for me, and I'm going to listen to a few talks after this. That'd be lovely. For those of you who don't know anything about the MS Society, just a few words. So essentially, our vision is that people with MS should have no effect on their life. That's it. It's a world free from the effects of MS. We have 35,000 members, 5,500 volunteers, 265 staff, which I'm one of them, and 270 local groups. And the orange dots are all the groups that essentially support people locally with services. Often a cup of tea is often the most thing that's needed, actually. So we support, we do lots of different things, aside from funding research, we fund services, support, we've got a helpline, lots of different things. We're the largest UK charitable funder of MS research, probably in Europe as well. We currently spend around 6 million a year, around 70 active projects. I can see a few grant holders here, and our active portfolio is around 20 million. So, and I'll tell you a few of the grant types at the end in case anyone's interested and wants to have a conversation about opportunities. So that's us. And obviously I don't need to tell you how important MRI and imaging has been in the development of treatments and diagnosis for MS, but I thought I'd just say a few words. So I was actually looking through some of our archives last week, and I did a bit of Googling, and I understand that the first MRI scan done on a human was 1977, and I found a record in 1982 of a £1 million grant to Prof. George de Boulay. So that's really nice that within 5 years that we got on the bandwagon, and actually that works out about £3 million in today's money. And then, as you can imagine, there was several £1 million worth of grants that went to Prof. Ian MacDonald after that. And you know, we set up the MRI. Well, the funding set up the MRI unit here. So you know, we're really, really pleased to have done that. And you know, I don't have to tell you how important that, you know, that research has been for improving diagnostics, making them faster, non-invasive, and also you know, without MRI, you know, the treatments, disease-modifying treatments, those developments just wouldn't have happened in the way they did. So I don't need to tell you this, but I just thought it's always nice to say it again, and it was nice to kind of look back through our archives and see that we how much money we've spent on scanners in the past. It's all worth it though. And then I wanted to just highlight, especially around spinal cord imaging, because I know that's what we're here today to talk about, kind of some of the areas that I think it's really important for, could be important for, and kind of the areas that we're interested in. So I've got a couple of slides on that. So our number one goal is to find effective treatments for people with MS to slow, stop, or reverse the accumulation of disability. Obviously, you know, there's been quite a bit of success for relapsing forms of MS. We have over 12, 13 licensed disease-modifying treatments, and that couldn't have happened really, those clinical trials, without using MRI outcomes. So, and I hope to think that spinal cord could be pivotal in the future when we're thinking about progressive MS trials and finding more sensitive ways to test treatments. And also, hopefully, the reality is it makes trials more feasible. You'd end up with less patients, less money, and they sound like minor things, but it really can be make or break whether you can run that trial or not, and whether that treatment then gets tested. So it's absolutely vital under our number one goal. So we're delighted with all the work that's going on. The other area where spinal cord imaging could really have an impact is around prognosis and personalisation. So people with MS, when they're diagnosed, often are told, we have no idea how your MS is going to develop. And that is something that we hear a lot, and it's really, really difficult for people to plan their future. So quality of life, we would like people to make better treatment decisions, choose treatments that might benefit them. They're more likely to go on to have a more progressive form. So this area of research, I imagine the spinal cord imaging would be absolutely vital. So, there's been developments made, I know, and breakthroughs, and we continue to look forward to seeing more in this area. And this is a priority area for us. If anyone's got bright ideas for grants, we would always want to hear them. And then I just wanted to kind of just tell you some of the opportunities in case you've got a grand idea. So obviously we're very interested in research in this area and supporting collaborations. We have lots of different grant types. We have an annual response mode grant round where essentially you tell us what you want to do. There's some different project types, project grants, innovative awards. So innovative awards are usually around £40,000. We've got kind of a slightly risky idea, something you want to test. Project grants are often for more money, longer term, 3 years, studentships, junior fellowships. And this year, our junior fellowships used to just be for sort of care and services support type research, but now we're opening these up to biomedical as well. So just keep an eye out for announcements about that grant round that will be happening this year. We also commission research as well in various centres and bits of infrastructure. We do a lot of work around clinical trials, commissioning pieces of underpinning work that might be needed to support trials. And then lots of collaborations. So if ever you've got a funder that wants to fund something but you haven't got quite enough money, come and talk to us. We fund lots of things in collaboration with the MRC, NIHR, lots of other initiatives, and internationally as well. And I think this type of research obviously bodes well for collaboration. So do get in touch with myself or the MS site if you have any opportunities you want to discuss. The only other thing I was going to mention was just a really exciting project that we've kind of spent the last couple of years working on. We're going to be setting up soon a large platform trial. The idea being a multi-arm, multi-stage trial where you can rapidly test new treatments and kick them out when they're not looking like they're any good. And kicking them out is absolutely dependent on, at the moment, on using whole brain atrophy. But what we would like to be in the future, Frederick's nodding, is to be able to use spinal cord atrophy to make it a more sensitive measurement so we can use less people. And it sounds silly, but we're doing some power calculations to work out how many people you need per arm, how long trial duration is. And it's different. It can be the difference between doing a trial and not doing a trial. So, this is a really important application of this. So we look forward to seeing how that all pans out. And I think that's all I was going to say, was just to say thank you to you all for all your work, and more importantly, all the work you're going to do. And I hope you have a really great conference, workshop. I hope it's thought-provoking. I hope there's lots of collaborations, lots of bright ideas. And if you ever want to get in touch, that's my email address at the bottom. Yeah, enjoy. Thanks.
Thank you. I don't know if someone wants to ask something.
Yeah,
Because,
yeah. You can always drop me an email.
well,
Yes, you can have money.
yeah, well,
You can always ask.
You can always ask. I can say no.
I would like that you explain a little bit more there is one of the grants that you put at the end, and the one about the trial, the optimization of the trial platform.
Yeah. This one.
No, the previous. Yeah, this one.
Yeah. That's this.
What is going to be this one?
Oh, so sorry.
Yeah.
That project is essentially what I was talking about here.
Okay.
So it's I don't know if anyone's ever has been aware of the Stampede prostate cancer trial, where it's multi-arm, multi-stage. So you run essentially phase 2 and phase 3 in one go, and you can test lots of different treatments at the same time. And then the ones that work, jump ahead and go through to what is essentially phase 3. It's a really, really efficient way of doing trials. And in prostate cancer, they managed to change practice 4 times previously when people with advanced prostate cancer had nothing. So we really were inspired by that and made a commitment to raise the money to be able to run a trial on that scale, where we want to test initially 4 treatments for progressive MS and add new ones in as and when the science is there. But what's so important about that is to be able to have the measures to be able to make that decision, so you can chuck drugs out that don't work and add them in. MR outcomes are kind of where it's at for these trials, and we want to see the success that's happened in relapsing MS happen in progressive MS. Currently, we're going to use whole brain atrophy and look after 18 months to see if we can see a reduction in the rate of shrinkage. But we'd love to do something. I know Frederick had a grant as well to kind of test, to fiddle around a bit, see if he could use spinal cord imaging from the existing whole brain atrophy scans.
I'll share some of the results tomorrow.
Yeah. So so it's really, really exciting, and there's lots of opportunities. And with these trials, you can change outcomes. You don't have to stick with whole brain atrophy for the rest of it. You can change drugs, you can change outcomes, you can change cohorts. So there's lots of opportunities for different measurements to be used, sub-studies, secondary outcomes, lots of different work. It's going to be based out of UCL. That was the winning bid, and the clinical trials unit is going to be the MRC clinical trials unit in Holborn. So there's lots of opportunities for ideas to be tested via this. There's going to be thousands of people in this trial, so do have a think about things you can do with that data, I think.
And
Is that kind of what?
Yeah. And because not everybody here is from UK,
Okay.
can people from overseas apply for UK MS Society grants?
So for the open grant round, not on their own, has to be a collaboration with a UK institution, but other grant types we'd be interested in funding or co-funding with other funders. So if you have something in mind, ask me and I can tell you if there's a route to that. But they have the host institution for these ones has to be UK. But also we have lots of good relationships with other MS societies as well, so we can always do a collaboration or put in a good word, things like that. So and then we can kind of commission, if we commission work, we can commission who we want to do that. And we hope that within the trials platform as well, there might be international sites as well. That would be the hope. So it will be run out of the UK, but there's no reason why there can't be international sites. We're going to need to recruit quite a lot of people and add new arms and hopefully new sites as we go through. So there's lots of opportunities, I think. There you go.
Thank you.
Yeah.
Any question? Thank you very much.
Thanks.
Okay, the coffee should arrive now because the idea was to do a coffee, but he's not here. Then I don't know. Maybe we can move forward to next presentation while we wait for the coffee.
Let's keep moving.
Yeah, because as people can ask a lot of questions, then we can delay a little bit everything. Julian, I think that you are the next one. Are you going to present with your computer?
Yeah.
Yes.
Oh, actually, I mean, you can also do
It's the same. Yes.
So check if you see the pointer wherever. Because I have a green pointer.
Babna and Marius are going to share this session. And start.
Press the continue.
Yeah, I think no. I was just comparing red and green for the Zoom for the remote people. Green is better, which means that just this one. Okay. Hello, everyone. Thanks for coming. I see the room is full. Maybe we can grab a couple of chairs. Maybe we can move some of those.
Yeah, there are chairs
Then,
there.
yeah. Please come in the front. Don't be shy.
Front row seat. All right.
All right. So it means that I have until 3 p.m. That's right.
Yeah.
Just joking. Okay, so going to talk about standardizing acquisition and processing of spinal cord MRI data. So I've been giving this talk for the past 3 years, I think, because this is a fairly long project that is almost getting towards the end. So for those who already listened to my talk, there will be some overlap, but there are also some new material. So don't get your coffee yet. Very brief introduction about what quantitative MRI is. This is basically a term that hides like a goal that that we are trying to reach, which is to basically get values, absolute values from the MR scanner. And those values would mean something specific to the microstructure. For example, the integrity of axons, something that relates to myelin content, to axonal loss. And similarly to X-ray and CT, we would like to get absolute numbers so that we can derive absolute values and normative values, and then compare those values from an individual subject basis. As you know, there's also fMRI and spectroscopy, and ultimately, quantitative MRI or qMRI aims at improving diagnosis, prognosis, and monitoring of new drugs and trials. As you saw before, there is a lot of techniques out there behind the term quantitative MRI, and every year research groups are innovating and finding new techniques. But from a practical standpoint, if you were to start a clinical trial or to put something together in your center, it can get very overwhelming to basically choose between all those techniques out there if you want to stick to, let's say, a 25-minute protocol to insert into the clinical routine. So with that limitation in mind, a couple of years ago, we started initiative called the Spinal Cord Generic Protocol. And the basic idea is to propose to the community a set of sequences that, very importantly, are product sequences. So you don't need any research key or like WIP, C2P, things like that. It's basically already available from your multi-million-dollar scanner. Available for the 3 main vendors, GE, Siemens, and Philips. And we are currently working with Toshiba to also make this protocol compatible. And multiple sites, experts in spinal cord imaging, have been collaborating, including UCL, so that we could reach some consensus. This project is really about finding a consensus that everybody would agree. And it's a protocol at large. It's not specific to MS, not specific to spinal cord compression, but we really wanted to find a protocol that has this qMRI signature that could be applied to multiple pathologies. Very importantly, We also spend time creating documentation material for MR techs, who ultimately are the ones behind the console. So they have an extremely important role in the quality of the images that people are going to use down the line. So there was a lot of iterations with different MR techs from different groups in different languages to make sure that things are understood well in terms of patient positioning, patient preparation, and also slice positioning and so on. And a derivative, it was not discussed 3 years ago, but this kind of collateral project also came along, which is to basically generate a publicly available data set, which is the very first quantitative MRI data set of the spinal cord. And we have 2 of them. One, which is a single subject, multi-site, and it's been uploaded. It is now available on Open Neuro. It's been uploaded last week, so you can all have access to it. And also a multi-site, multi-subject data set. And this one has been available for the past 6 months or a year. And there will be some sort of a white paper coming out of this study as well. So this protocol includes a brain and spine. So this is really to get a full picture of the brain and C-spine, including the brainstem, using a standard MPRH type sequence, which is about 5 minutes. A higher spatial resolution and T2 weighted, which is less sensitive to motion. So we like to use this one for measuring cord atrophy. Also, diffusion weighted imaging protocol that is basically, it's a single shell, so it can be used for diffusion tensor imaging. If you want to use a more advanced protocol, you can modify the protocol. If you want to do like NODI, for example, or STEADY, or like other types of models that require more diffusion directions, more shells. And this DTI is sensitive to demyelination in the white matter as well as axon degeneration. Magnetization transfer protocol, which is more specific to demyelination. This one includes also a T1 weighted scan so that we can derive magnetization transfer ratio as well as MTSAT, which is a technique that has shown to be less sensitive to T1 bias. And lastly, high in-plane resolution GRE scan in order to have a good contrast between the white and the gray matter. So that could be used for measuring gray matter atrophy, for example. So depending on the vendor and on the software version of the console that you're running, the acquisition time is about 20 to 30 minutes. So it's reasonable. It can reasonably be included into a clinical protocol. And importantly, people are free to choose, to get rid of the T1 weighted MPRH if they already have something similar, or it's basically a pick and choose type of thing. But the idea is that, if many centers start following, directions along those lines, it will be easier to then pull data together and start some retrospective studies, for example. Also, something new that we've been working on for the past couple of months is that we spent a lot of time on documentation. So there is a website which is formatted by Read the Docs, which basically includes all those information about how data were collected, as well as how data are analyzed. So all the analysis pipeline is available. The codes can be downloaded. There's also some tutorials and video tutorials for people to reproduce those analyses. And this is not specific to the spine generic protocol, but this has been designed and documented also for people to basically create their own study and work on their own data sets. So very briefly, the way, are there any questions maybe so far? I see the copy just arrived. Yes?
Do you have already protocols for VIDA?
Yes, so it's so we go up to, so VIDA would be VE. So I mean, so we have validated the protocol until VE 11C. So some VIDA scanners do run this software protocol, but now Siemens has released a new and updated protocol, and so we've been working with them, and there is almost no change with the new scanner. So yes, we do expect that the protocol would work. So the analysis pipeline goes like this. So it starts with a T1 weighted image where we segment the spinal cord, and then the vertebral levels are labeled. On the site, there is the PAM50 template, which is the reference spinal cord template that we use for doing atlas-based analysis. It's composed of 50 individuals, and PAM stands for Polytechnique, Aix-Marseille Université, and the MNI. The subject is registered to this template, very similar to what we do in brain studies. And then using this information from the different labels and the spinal cord segmentation, we can compute the cord cross-sectional area at specific vertebral levels. We do the same for the T2 weighted image, segment the cord, and thanks to the pre-registered templates, the working field that we have, we can also compute the cord cross-sectional area. With the multi-echo GRE sequence, we segment the gray matter, and then we can, from this segmentation, compute the gray matter cross-sectional area. The MT protocol, which consists of an MT with an MT preparation pulse, without the preparation pulse, and this is the T1 weighted sequence that I told you about to mitigate this T1 bias. There is a co-registration, segmentation of the cords, registration with the PAM50 template to extract the probabilistic white and gray matter atlas that is then used to compute MT-based metrics within the white matter. And we do similarly for the diffusion weighted scans. There is a motion correction step, and then segmentation, registration with the template, and then estimation of the DTI-based matrix inside the white matter atlas. So I'm going to show you now results in this single subject, which was me, scanned 18 times across 18 sites. So first, I'm going to show you the result of the cross-sectional area that was averaged between C2 and C3 in order to get a better precision. So these are the results. In Abscissa, here you have all the different sites. You see a lot of Japanese flags because I did that mostly during my sabbatical in Tokyo. But there is a fairly good representation of the different vendors, GE in black, Philips in blue, and Siemens in green. There are some outliers because it was still during the optimization protocol, optimization phase. So we had to face some different software versions. We had to adapt the protocol on the fly, and it was not always possible to find on older software version an equivalent of the sequence. So in some cases, the outliers were not included in the calculation of the statistics. What you have, the numbers you have here is the average of the cross-sectional area in millimeters square, and it's a standard deviation. The standard deviation is taken within vendor and across sites. Okay. So the thing to notice from here is that the standard deviation is fairly small. In most cases, it's below a millimeter square, which is really the size of a pixel. So we get an extremely good precision, which is sub-millimetric, sub-pixelar. And the coefficient of variation, the inter-site within vendor coefficient of variation is less than 3% across all vendors. And it's less than 1% for GE and Philips. So I'm skipping the T2 weighted, just jumping to the diffusion tensor imaging results. You have all the sites here, and what I'm showing in the ordinates is the fractional anisotropy from the diffusion tensor imaging. And again, we had some issues with two sites in terms of software version where the sequence was not available as it was for the other sites. In this case, we also didn't use the pulse ox, and that created a lot of bias in the matrix. So if we exclude those outliers, the intra-vendor inter-site coefficient of variation is less than which is also very good. So this was for the single subject. Obviously, I mean, we would assume that within 6 months, my like the anatomical, the microstructure of my spinal cord didn't change. Although we could question if there are some circadian effect, for example. I don't know, but the idea of moving to a multi-subject study was to get a bit closer to the in situ usage. So what I showed you before was really the best of the best in terms of efficacy. We would expect the same value across sites, right? This project, which involves a lot of different sites, was more about efficiency, which is how the protocol could be implemented by each site without me being present and instructing the MR tech how to orient the slice and so on. So this was really an evaluation of what's the variation that we would expect inter-site, inter-vendors, inter-subjects for a routine, for a realistic routine scenario. A corollary interest of this study also was to provide a publicly available data set that could be used for generating normative values and also for computer geeks to basically play with the data, develop new models and so on. The analysis could be reproduced. So the results that I'm going to show you are based on the 4th version of this Open Neuro dataset, and the analysis pipeline was also released on GitHub. So first of all, it's an example of an image quality that is basically, so it's showing a sagittal image of the T1 weighted scan across all the different sites. So you can see that all sites except a few respected the standard operating protocol, the SOP, in terms of FOV placement. There were some issues with other sequences. I'm not going to dive into the details, but I would say that overall, all the sites did respect the SOP, which is great. This is the result of a cross-sectional area for the T1 weighted scan. So again, like for the single subject, the CSA was averaged between C2 and C3. And in black, these are the GE scanners, in blue Philips, and in green Siemens. And I've also added the model of the scanner here for each of the bar. So we really have an extremely good representation of all the different models. We even have the trio. You have trio? I think we have trio. Oh yeah, we have one trio. And potentially in the future, we'll also include other models like VIDA, for example. But the take-home message is that we see a fairly good like inter-vendor agreements between Philips and Siemens. There seemed to be a slight downward bias for the GE scanner, which could be explained by parameters like such as TE, for example, which might differ a little bit, and that would make the contrast between the cord and the CSF to change a little bit. And as you know, since the CSA is based on the segmentation and the segmentation is based on the contrast, if the contrast changes a little bit, it would also change the definition of the boundary between the cord and the CSF. So that's how bias could appear. That being said, the coefficient of variation is written here. So for those in the back, it's about 7 to 8% for the intra-site. So within a site, the coefficient of variation is about 7 to 8%. And inter-site, basically we take the average of each individual, and then we look at the coefficient of variation within vendor, right? And this inter-site within vendor coefficient of variation drops to about 2 to 4%. And that's something we would expect because we know there is a lot of variability in terms of cord size across subjects. So we don't expect, like all the subjects within the site to have the same cross-sectional area. However, we would expect the coefficient of variation to drop if we average that across the different sites, right? Because ultimately we would because of the central limit theorem, we would expect basically the distribution of the cross-sectional area to be similar across the population. And so if we sample 6 people in different sites, we would expect the average to be similar.
Is there any corrections for size of the subjects? Or?
No, there was no correction at all because and it's an extremely interesting point so far, and that's something we could definitely discuss. I'm not sure what's the best way of normalizing it. There's a lot of literature out there.
There have been some papers looking at it, and I think most of them conclude that there's some effect, isn't it? Of persons,
there is some effect of person's height, although we've looked at it also. We were not completely convinced by that. Yeah, I'm not exactly sure what to, but I would love to, to basically have a good predictor because if there might be something out there. Yes? That's a good point. We have not looked at that, but the data out there. Ethnicity background is not encoded in the database for privacy reasons. So I guess that could not, yeah. I mean, internally we have the information, so maybe there could be something to look for, but that could not be a public, let's say, like a fully disclosed information. But it's something that could be worked on with the dataset, definitely. Yeah. It's a good point. Okay, so obviously the next question is how can we, if people were to derive multi-vendor clinical trials, how would we manage the different contrasts? So that's an example of the T2 weighted image across the different sites. And the cross-sectional area results, what you see is that the average cross-sectional area is slightly higher than for the T1 weighted image, even though these are the same subjects, right? The coefficient of variation are on the similar order, so about 7 to 8% intra-site, and about 3 to 5% inter-site and within vendors.
It's a bit more variable.
It's a bit more variable. It's a bit more variable. Yes, it's a bit more variable.
So yep. Which one you recommend, T1 or T2?
So I would in fact recommend the T2, even though those results suggest otherwise. Yeah, so the reason I would suggest T2 is that by experience, I find them a bit cleaner and less prone to motion. We need to remember that, this is, it's presented as like a realistic in situ scenario, but in fact, I would expect that clinical scans done routinely would show more motion on the T1 weighted scan, whereas the T2 would be would be more forgiving. So even though for this, like subjects where, these are like very respected research sites, all of them, and subjects were prepped, very well. So this is not like realistic clinical scenario. So, but based on this intuition, it needs to be demonstration. I would still recommend the T2 weighted scan. It also has a higher spatial resolution than the T1. That's my point of view. So the next natural step would be to look at the difference between the T1 and the T2. So if we plot the agreement in terms of cross-sectional area for the right. So this would be the T2, and this would be the T1. Okay. For Siemens, Philips, and GE. So Siemens and Philips are in fairly good agreement. GE is slightly outside and more spread out. We can also look at it across, like within vendors. And one use of this graph would basically be to obtain some sort of normalizing factors, so that if people were to start a study using the same protocol across vendors, then they would have a way to normalize their data across the 3 different vendors. So that's one deliverable of this study, which could be useful. So that was it for the cross-sectional area. I'm now going. Yes.
Have you tried this for your brain? Well, your spine that has been scanned in 18 different sites.
I have not. I have not.
Maybe is the way to.
Absolutely. Yeah, that's a good idea. Absolutely. The talk is recorded, so I won't forget. So. Yes.
But how many subjects did you start?
Right. So we asked for. Yeah. So the subjects are shown here. We asked for 6 subjects, 3 male, 3 female. Some sites offered more, and I said yes. I think Oxford provided 12 per site or something. I'm not going to reject those subjects, obviously. But the minimum was 6. Yeah, and most of the sites provided 6. Yeah.
And for other subjects, single examination and repeat examination.
Repeated. So no, there was no scan rescan. It was only a single shot imaging.
And the massive data is going to do that. So that's important.
So we don't have any scan rescan for each of those subjects.
Haven't got all this effort.
That
would be the final.
Right. So I'm not sure at this point. I don't think it would be important because, for example, the reason I don't think it's important is because, let's say we would so the test-retest would inform on the precision for like for the same subject, right? And this table here includes that variability. So basically, that result here includes the variability of the test-retest, even though it was not done, but it was done across different subjects. So across subjects, we would have the variability of the scanning session per se, as well as the variability across subjects, variability within sites, as well as across sites and across vendors. So we could have asked sites to, to redo the same examination 2 times, 3 times. But the question is, what would we do with that numbers, right? Yes.
Maybe you can do it 1 year later or something. You can also scan them, and then you can look at change as well as scan rescan.
You need to sample with. I'm not suggesting you to everyone again, but certainly a subset would be very. Because basically that's what we try to measure.
Right.
But when individuals scanning a single scanner, I mean, how much is their spinal cord cross-section area?
Sure. Yeah.
And a big factor on that is how is an individual scanning changing over 12 months?
Sure. So that was, I mean, it's in some ways this information is there in the single subject results, right? Mm-hmm. Because you have 18 temporal points within the subject, right?
The temporal.
It's over about a year. It's a single subject, but still provides part of the answer, right? If sites are interested in rescanning subjects, then they are free to do that. I'm a bit tired with this project, I have to say, but I might give a bit more effort. So yeah, the next contrast metric is the diffusion tensor imaging. So I'm only showing the FA here. All the sites here, same orders, same vendors. Coefficient of variation intra-site is lower than for the cross-sectional area, which is very interesting, actually. So we do expect the chord to change, the chord morphometry to change across subjects. But what we see here, and it's very consistent across vendors, is that the FA within the white matter does not change as much as the cross-section area, which is like intuitively we would think that, because we would think that the white matter across people is made of same types of axons. So the intra-site coefficient of variation is about 5%, less than 5%, between 4 and 5%. And inter-site, so if we do the average and we look at the coefficient of variation, it's between 2 and 4%. So it's again very reasonable. And to me, this precision can be used for doing power analysis, for example, in clinical trials, even longitudinally. Looking at the magnetization transfer ratio here, we have a fairly good agreement between Philips and Siemens. GE is using another type of pulse for magnetization transfer. So we would expect the MTR to be different. Okay, there are some outliers that are related. So in this case, the software version did not allow to use the TR that was the same as the other side. So if we change the TR, the MTR changes a lot. So that's expected. The intra-site precision is still good. So overall, the precision is nice. It's about 2 to 4.5% intra-site. Okay, so we have a better precision than with FA. We also have a better inter-site precision. The coefficient of variation is about 1 to 2.5. Okay, so an extremely good coefficient of variation. It also raises questions about the sensitivity to disease. So all those subjects were supposedly healthy. What happens if there is a lesion or an abnormality? How much of how the effect size, how big the effect size would be is another question, right? Because precision is one thing, but it needs to be normalized with the effect size. So something very important to keep in mind.
Okay.
Yes.
Again, on each of those measures, GE site seems
be slightly different in some way. Is it significant or not?
I haven't done any like statistical comparison because I was not sure what my null hypothesis was. But I guess, I mean, yes, they are different. I mean, for the MT, the difference is pretty drastic because the pulse is different. If we look at the DTI, it is indeed quite different. Noise properties might be different. The filter also that they apply during the image reconstruction by experience look more different than the filters they apply on Philips and Siemens. Yeah, I don't really have any like other insights apart the fact that the intra-vendor precision seems comparable. So if there's bias and we can account for it, I wouldn't be too worried. Yes?
Sorry, just to add a comment to this, I think the pulse sequences that is laid out by individual vendor is going to be different.
Yeah.
For example, the MT, you will have a different frequency, you will have a different power. So you're probably not going to get the same MT effect if you go from vendor to vendor. So it's important to know the hidden parameters that are in the pulse sequence. And even for DTI, I think the gradients, gradient strength, gradient duration, intergradient separation, all those things might be slightly different. Final outcome.
Yep. So next things to do would be to reprocess the single subject data using the updated pipeline. So that's something still on the to-do list. For the multi-subject data, wanted to implement a protocol validator in order to check the TRT, just to make sure that they are the ones that were asked by the generic protocol. I didn't check for that. Further interpretation, maybe looking at statistical differences and possibly excluding, like interpreting, also knowing that some sites might have used different parameters. Verify the manual corrections, and then finalize the manuscripts, and possibly also doing this longitudinal study that would definitely be of interest, but I'm not sure this is going to happen. But it could be on the perspective. So to conclude this talk, the spinal cord generic protocol was really created to promote replicability and dissemination of knowledge. Hopefully it minimizes wasted time and money spent on pilot scans by each center new to spinal cord imaging. Hopefully also this consensus and standard protocol aims at minimizing the inter-site variance. And it's currently implemented in different initiatives. The Inspired project that is led by Claudia Wheeler-Kingshott, Armin Court, Michael Fellings, and myself, and Patrick Freund as well. The CAN protocol, which is a pan-Canadian initiative for MS research. The NAMES, the North American MS Society, also discussed this protocol, and there is also discussion to implement this protocol for spinal cord injury through the NIH, NINDS common data elements. Like talking now about analyzing those data, there is also an incentive, like in benefits in using standard tools. The idea of having them open source is basically, for obvious reasons, makes the analysis fully transparent, as opposed to basically feeding the data inside a black box proprietary software, and results come out and we don't really know what kind of filters or registration or any algorithm was applied. Also promotes cross-validation and of the published studies. And the idea of having automated pipelines, aims at minimizing user bias. When basically people draw manual ROIs, different people might draw different MRIs, and therefore results might be different. This is especially sensitive in the spinal cord area, which is a very small structure. And if we decide to include the voxel or not, then the average FA would be drastically different. And down the line, this has tremendous implications, because then we use that FA to look at patient differences or longitudinal effects and so on. Normative values could be used for clinical studies based on the results that I showed you today. So my postdoc, Ivan Onzo-Ortiz, has submitted an ISMRM abstract that she will hopefully present at in Sydney. And the take-home message is that the recent paradigm shift in acquisition and analyzing spinal cord data will hopefully pave the way towards a more systematic inclusion of the spinal cord in studies at large. So I'd like to thank everybody in the lab. We are recruiting. Canada is a nice place to live. Even members of the royal family decided to live there. Thank all our collaborators who contributed to this multi-center protocol, as well as the funding sources, and thank you for your attention.
Any other questions? Right, quick one.
Sorry, for your segmentation pipelines, I'm interested whether you use ProcSeg or DeepSeg, or what's the difference between
We use the DeepSeg.
Use the DeepSeg, yeah. So that's always like highly recommended.
I would say so, yes.
For
Yeah.
T1 and T2.
Yeah. Yes?
Yeah. Maybe I misunderstood, but I thought you said you had different ways of segmenting the white versus the gray matter cord. Is that correct? That you got the gray matter from the multi-echo?
So we have the
probabilistic atlas, or maybe I missed.
Right. So we segment the gray matter on the GRE scan. We also segment, I didn't show it, but we also segment the spinal cord on the same scan, and then we do a subtraction between the cord and the gray matter.
But then at some point you use the template.
And then
probabilistic atlas to get the white matter.
Right, and then
the FA analysis or something.
Right. So and then we register the PAM50 template to the individual scans, which could be the MT scan or the diffusion scan. And it's probabilistic in a sense that it was built by Aix-Marseille, by the group of Virginie Callot, and so they basically estimated like a gray matter shape based on a few individuals, and then that was registered inside, that was fused with the PAM50 template. And the other aspect also to keep in mind is that when we warp this probabilistic atlas to the template space, we don't create a binary mask, which is, like traditionally, this is what people did, we use like a soft mask in the sense that it's weighted between 0 and 1, and it accounts for partial volume effect. So, for example, voxels that would be at the vicinity of the cords or at the close to the interface between the white and the gray matter would be weighted less than voxels that would be more central to the white matter.
Still, why would that be better than an individual white matter segmentation that you have?
So how do you segment the white matter? I mean, how do you segment the white matter tracts?
Yeah.
So, okay, right, I see what you mean. Okay, so
if you're talking about specific tracts, then yes.
Yeah, so I'm talking
That's
about
what you mean.
I'm talking about specific tracts.
Yeah,
exactly. Yeah. In that study, the FA and so on that I show are in the whole white matter. So I could have used simply the segmentation of the white matter, but yeah, the results are extremely similar at the end, and it enables to interrogate other tracks as well.
Okay.
Going back to the MTR results, and answering this question might violate a whole bunch of NDAs, but so the fact that the Siemens and Philips results look very similar, does that then imply that their MT passes are also reasonably similar to each other?
So the MT pulses are, so first of all, the frequency is the same. I can say it is 1.2 kilohertz. I don't think I can say it. Anyway, it's too late. But I think it's also the same type of sync pulse. G uses a binomial pulse, I think. And there, although like we really tried to match the parameters as much as possible. I don't have all the parameters on top of my head, but you know, the important ones, TR, TE, flip angle, were the same. Yeah, and also the number of phase lines, which impacts the contrast. So yeah, it was easier for us to match the Philips and the Siemens than the GE.
Thanks, Julian. Thanks.
There is a question here still.
Sorry. About the implementation of order T1 against T2. So you have slightly recommended T2 because it's less sensitive to movement also. But do you have the impression also increased stability against pathology? I mean, because T1, for example, in multiple sclerosis, in other pathology groups, demonstrates to be not that sensitive, for example, to the presence of one item. The same applies also for two.
Right. So I mean, I guess we do see like hyper intensities on the T2 scan. I mean, I guess the EVMS experts would probably have better insights than me. I guess we also do see a hyper intense signal on the T1, but it might be less pronounced. I know that the MP2 range is getting a lot of popularity, which is like a very similar sequence than the T1 MP range. So that that would be an argument for if people are short in time, the MP2 range might be the way to go because it does include a T1 map as well as like a uni and a T1 weighted scan. Yeah, I guess more studies probably need to be need to confirm this. Yeah.
Okay, thank you, Julian, and we would like to invite.
No, we can do a short break for the coffee because the coffee is there now, and then we ensure that everybody has a chair. No, because it's a little bit. Yeah, we do the coffee right now.
Hey man, yeah. Again. Well. Yeah. Okay. I went out this morning and actually walked to the Tower of London and wandered around there for 2 minutes. And I was like, oh, this starts in a few minutes. I gotta get back. Pleasure as always. Hi, I'm Nuno. I don't know if you remember we talked. Yes, absolutely. Oh, that's Paul. We're going to point it. I didn't know. Pleasure, man.
Okay, everyone, it's a pleasure to introduce Dr. Jales Paniker, who is a consultant neurologist at the National Hospital for Neurology and Neurosurgery. He's going to speak to us today about the lumbosacral spinal cord.
Good afternoon, everyone.
I've been asked by Farhan to stand around here so I can see myself there, so I'm in the right place. But it's lovely to be here. As Mario has mentioned, my name is Jalis Pranik. I'm a neurologist, so I'm a clinician. I'm not an imaging scientist. But what I'm excited about lumbosacral cord imaging is the clinical applications, because I'm a neurologist with interest in uroneurology, so anything really below the belt. So bladder, bowel, sexual dysfunction, which essentially the centers for which are in the lumbosacral cord. And there are so many sort of unknowns about bladder, bowel dysfunction. And I feel that the reason why is that we don't have adequate imaging of this region of the cord. And hopefully through the slides that you see, you'll be convinced by that. I do feel slightly out of order, but I see Klaus coming in as a fellow clinician. I know there are a few other clinicians here as well. So I will start with telling you a little about the lumbar and the sacral cord before we move on to the applications. So many of you will know about the lumbar segments and the sacral segments. So essentially, if you sort of keep your hands on your laps, for example, you're feeling the areas which is the dermatomes in the lumbar segment. So the lumbar cord innervates, so sensory-wise, sort of, as you can see in this diagram, sort of predominantly over the anterior thigh, over the knee, the leg, over the foot. And these are sort of the lumbar dermatomes. If you look at the motor representation, these are essentially the lower limb muscles, or specifically sort of the thigh muscles and the leg over the foot, and parts of the gluteal regions as well. Now, the sacral spinal cord, we move further down, is really in the conus medullaris. Now, this is a really, really complicated structure because you have your somatic innervation, which I was describing to you earlier. So here, I don't know if you can see this figure in the back, but essentially you have your representations around the perianum, the perineal region, the back of the thighs. These are the sacral segments. Now, the sacrally innervated muscles, you have so the intrinsic muscles of your feet, but you have your perineal muscles, so the anal sphincter, the urethral sphincter. Now, what's unique about this area is in addition to the somatic innervation, you also have the splanchnic innervation that comes from here. So the innervation from the bladder, the bowel, and the external genitalia. So in the sacral cord, you have your anterior horn, specifically at the onus nucleus, which is sort of the anterior horn neurons that innervate your somatic muscles. And very close to it, you have the bladder motor neurons, which are essentially parasympathetic mediated neurons, which innervate the detrusor muscle, which is a muscle that lines the detrusor. Now, the bladder, or shall I say the lower urinary tract, is unique because it has a muscle that lines the bladder called the detrusor, which is innervated by the bladder motor neurons. But the sphincter muscles, which sort of the outflow, are innervated by the onus nucleus. So it's quite a complex innervation to the lower urinary tract and the bowel. But this is one area, therefore, of particular interest when there are suspected neurological disorders that affect the lower cord. Now, there's considerable challenges to MR imaging, and as many of you would be aware, that the vertebral spine does not correspond to the spinal cord segments. And this is particularly so in the lumbosacral cord, because at the bottom of the L1 spine, of course, the spinal cord is no longer there. And there's also a problem with reference points, because of the lack of an anatomical bony landmark. It's quite a mobile region, so the more caudally one proceeds, it's more and more caudal, because more and more mobile. And also you have your physiological movements, so not only the blood vessels, but also you have the bowels, you have from the kidneys. You have these sort of movements can also interfere with and cause considerable noise. So last year, you would have heard from Marius about sort of acquisition of images from the lumbosacral cord. So I'll just briefly go through how the sequence is developed. Essentially a 3 Tesla MRI acquisition protocol and analysis protocol, which has been published a few years back. And the superior margin, the T11 vertebra, is taken as the start of acquisition of 19 axial contiguous slices, which are perpendicular to the cord. And the cross-sectional area that you heard about in the previous talk was measured at the lumbosacral enlargement. Now each slice is 5 millimeters, so it's the slice above, slice to the largest area, and the slice below. And so this is, so by this one acquires slices, and then a segmentation software is applied. But before that, I think the problems that one of course is the position of the patient and immobilization. And this is particularly important for this area for the reasons I explained earlier. So strapping the trunk down, very tight, I must say at times, but which is feasible, and it's been comfortable even with patients with neurological disease, but also using padding in appropriate places to keep the neck mobile, keep the neck immobile, but also to keep the hip flexed at a particular angle is important. The team at the Queen Square MS Center has used correct use of sort of saturation slabs to reduce the effects of this physiological motion. And coverage between T11 and L2 ensures that the lumbosacral enlargement is covered. And that's relevant when we come to sort of conus medullaris imaging later on. But using a software that analyzes segmentation, the total cord area is measured, and the gray matter, and from that the white matter area is calculated. And in that original study of 10 healthy volunteers, reproducibility of this protocol was demonstrated between scan and rescan, and between in the same observer and also inter-observer. Percentage of coefficient of variation was reasonable and comparable to the cervical cord. Now, the conus medullaris is further challenging because it's basically the tip of the spinal cord, essentially floating in the CSF. Quite a bit of variability, therefore, not only in the position, but also the length itself. It ends at, we say at the bottom of L1 from a clinical perspective. However, we know there's quite a bit of variability to where the conus medullaris ends, or where the spinal cord ends. And so, but in a subsequent piece of work, the team has demonstrated has developed a protocol for imaging the conus, once again showing a reasonably good percentage of coefficient of variation, intra-observer and inter-observer variability being actually minimized. Now, because of the variability with regard to the position and the length, it's quite important to use normalization metrics here. And I won't go through the details here of how these metrics and how they were applied, but applying this, essentially the percentage COV was found to be reasonable. And also the group has also demonstrated MTR and acquired sequences, MTR sequences, and this is an MTR map from the lumbosacral enlargement. Now, what are the clinical applications of this? So when it comes to sort of a compressive lesion, either an intrinsic or an extrinsic compressive lesion, I think the images, the sequences that we have in clinical application are reasonably good. But when it comes to the non-compressive etiologies, that's where having a high resolution sequence would be a particular clinical application. So even sort of demyelination of the cord sometimes can be missed in the routine sequences. And time and again, you will come across patients where you clinically suspect that there's a conus lesion. So how would I suspect that? Is that the patient might have multiple sclerosis or might have a risk factor for stroke, be presenting with urinary retention, which means the bladder muscle is not working. And this is very odd for someone with MS, where you expect the opposite. You expect urinary incontinence. And so in such a sort of a scenario, which is actually not uncommon, therefore clinically suspect that there's a plaque in the conus, which is of course being missed in the routine sequences. Now, what is more challenging is actually neurodegeneration. As all of you are aware, the routine MRI sequences are even in the brain are often not sensitive enough to pick up volume loss in different sort of synucleinopathies, such as Parkinson's disease or multiple system atrophy, till very late. And this therefore delays the diagnosis. So what we're looking for, therefore, is an imaging biomarker in these neurodegenerative conditions. Now, I'd like to introduce you to one of the Parkinson conditions called multiple system atrophy. So all of you have heard of Parkinson's disease. You know that Parkinsonism is an umbrella term, of which most of the cases that you come across are Parkinson's disease. But you do have some conditions that mimic Parkinson's, And to even the most experienced clinician can get it wrong, whether it's Parkinson's or one of the Parkinson plus conditions. And one amongst them is a condition called multiple system atrophy. Now, this is very unique among conditions because it actually presents in a large percentage of cases with problems with bladder, bowel, sexual problems. These patients will end up in a urology clinic rather than a neurology clinic initially. The diagnosis is delayed. Unlike Parkinson's disease, where the lifespan of the individual is just like individuals without Parkinson's, with MSA, the lifespan is very much shortened. The people are usually dead within 10 years. So we lose a considerable amount of time because the patient doesn't have a proper diagnosis. Yet they present with urinary retention, sexual problems, and bowel problems. It is uncommon compared to Parkinson's disease, but if you work in a tertiary neurosciences unit where there's a strong neurology department, invariably there will be patients with MSA who come to the clinics, where often the question mark amongst the clinicians, is it MSA or some atypical form of Parkinson's disease? So in MSA, what happens is the patient can have retention because the bladder motor neurons are affected. The patients can have stress incontinence because the sphincter muscles are affected. And if one puts an EMG needle into the anal sphincter, there's denervation suggesting the Onif nucleus. Therefore, we know clinically that the sacral cord is affected. Now, pathologically, we also know that the sacral cord gets affected early on. And so there are maps, cytoarchitectural maps showing the neurons, the distribution of the different neurons in the sacral cord. So the Onif nucleus is what's called a hybrid nucleus. It's a hybrid between your sort of anterior horn cells that innervate through the upper limb and the lower limb, and the autonomic neurons that innervate sort of the bladder, the heart, for example. It's one set of neurons that are particularly affected early on in MSA. So if it were affected early on, it could potentially be an imaging biomarker for MSA to make an early diagnosis. So if these patients need to enter a trial for neuroprotection, ones that are early on affected, where you have a signal that could be MSA, would be the ones that you want to take. You wouldn't want to take a patient who has florid signs of MSA, who's well into their journey. On the other hand, the other group of researchers who are interested in the Onif nucleus are the people who do motor neuron disease research. The reason being is that, as you are aware, the anterior horns are particularly affected in motor neuron disease, and this is why it's called an anterior horn cell disease. However, the group of neurons that are resistant to the pathology of MND are the Onif nucleus, and it's one of the last set of neurons that are affected in this condition of motor neuron disease. So what is it about the Onif nucleus which makes it particularly susceptible to damage in MSA, but particularly resistant to the pathology of motor neuron disease, is a clinical research question, which I think pathologically we've not been able to come to an answer to explain that, but perhaps by imaging there might be some interest. We haven't done research in motor neuron disease, but I'll share with you the work in multiple system atrophy. This is just showing animal model of MSA, where there's a clear neuronal dropout in the Onif nucleus and the parasympathetic neurons as early as 2 months of life of this animal model of MSA. So the aim of our collaboration between Claudia Marius and the MS Center and Uroneurology was to test sort of tissue-specific cross-sectional area and MTR measures from the lumbosacral enlargement and in the conus medullaris, and individuals with this condition of MSA, where we know clinically and pathologically there's some susceptibility to change, and also look at these parameters in terms of clinical scores. So, in our study, this is sort of there was individual detection of the LSC, and the mean cross-sectional area was measured across 3 slices spanning the lumbosacral enlargement, so 1 slice above and 1 slice below, and segmentation analysis, the gray matter and the white matter, and tissue-specific measures were obtained. The remaining caudal slices were taken and to acquire the whole conus. It was an individual basis, so each individual has a varying conus length, and so the images were acquired depending on when the conus is no longer seen. and also an MTR acquisition protocol that was also used in the study as well. So we had two groups. We had a group of individuals with probable MSA with bladder symptoms. They had an abnormal EMG, so we know that there is definitely some pathology occurring in the sacral cord. And the other cohort was 15 individuals who were sort of age-matched healthy controls. So this shows the individual trajectories. The row on the top are the healthy controls, and below are multiple system atrophy. And you can see the trajectories which start at 0 point, which is the lumbosacral enlargement. And as you can see, going caudally, which is in negative, towards the conus medullaris, this is the total cross-sectional area reducing. And this is in males, and this is in females. And these are sort of the group means. This is the multiple system atrophy group, and this is the healthy control cohort, and this is the total cross-sectional area. This is the white matter, and this is the gray matter. So 0 indicates the point of the largest cross-sectional area, which would be the lumbosacral enlargement, and so subsequently the ones in negative are indicating going towards the conus. Now, what was seen was in the group, so I'd like you to focus on this part of the table, was a significant difference in the gray matter volume at the level of the lumbosacral enlargement between the multiple system atrophy group and the healthy control group. And so the gray matter volume fraction was reduced in the MSA group. And this is the level of the lumbosacral enlargement. Now, conus medullaris measurements are far more difficult to acquire, but we were successful with acquiring them. And rather than looking at the cross-sectional area, because as you can imagine, that towards the tip, each of those cross-sections are going to be significantly reduced because it's basically the conus is tapering off. It was the gray matter volume fraction that was found to be, it was the gray matter volume that was looked at, and it was the gray matter volume fraction was significantly reduced in the MSA cohort compared to the healthy control cohort. This is just showing the cross-sectional area between at the level of the LSC, and this is between the MSA group and the healthy control group. Once again, just showing the significant difference. So what was shown was a reduced gray matter volume fraction of the lumbosacral cord, so the LSE, and the conus in the MSA group compared to healthy controls. Now, what we also did was we wanted to correlate this with clinical scores. And so remember the first diagrams that I showed you, that when it comes to the sacral cord, there's very little muscle to test. You can introduce a finger into the rectum and test the rectal tone, the squeeze, but that's about it. So here the clinical score we looked at was voiding functions, because we know about the bladder innervation from the sacral cord. And what we found was that indeed the degree of voiding symptoms was significantly correlated with the gray matter volume of the CSA, the gray matter CSA for that tissue. And there's a correlation between the degree of voiding difficulties and the reduction in the cross-sectional area for the gray matter, both at the lumbosacral enlargement and the conus. Now, in the study, we also looked at multiple sclerosis patients. Now, this is work in progress, but between 12 healthy controls and 12 MS patients, what we found was a significant difference in the gray matter. I think the numbers are small. We were actually expecting to find changes in MTR. But I think with the completion of the data set analysis, we would be interested to see what those results show. So this is the work that we've done so far. Rather new work in the last sort of 5 years about sort of now having a standardized high-resolution imaging of the lumbosacral cord. In preparation for this talk, I actually looked to see if anyone else has been doing this work. I did stumble upon a piece of work from Beijing. So this group has imaged the lumbosacral enlargement with an entirely different protocol and a different scanner. So probably not comparable with the work we've done. But the question they had was actually quite interesting, because they chose a group of patients with a cervical cord lesion. So these are patients with cervical compressive spondylotic myelopathy. And they were looking to see whether there could be changes in the lumbosacral enlargement. So these patients do not have a lumbosacral enlargement injury. And in the study, what they found, without going into too much details about the methodology of the study, is they found actually significant differences in DTI indices, so the ADC and the FA values in the lumbosacral enlargement between patients with a cervical spondylotic myelopathy compared to volunteers, which I think is interesting. I couldn't comment on the technique. However, it just seems to suggest that there is a dying back phenomenon that's occurring, Wallerian degeneration possibly, and the changes that are occurring in the cervical cord are having an effect caudally at the level of the lumbosacral enlargement. What they found also was that just that FA values at the lumbosacral enlargement there was no significant difference between at the lumbosacral enlargement between the CSM patients and the volunteers. Oh, so what they also showed was the FA values was no different between the LSE and the cervical cord, which I think needs to be reproduced, but is an interesting observation from the study. So what are the future applications for this? So though I'm a neurologist, I am interested in things in the bladder. And those of you who have an opportunity to work with an academic functional urologist will tell you that one of the burning problems is the problem of the underactive bladder. So the overactive bladder, if you were to go back and Google, there are lots and lots of therapeutic options available. But the underactive bladder, where the bladder has basically failed, it's just remaining a flaccid bag, and the patient's retaining urine and requires a catheter to empty the bladder, is a problem that's not been clinically solved because we don't understand why people have an underactive bladder. Essentially, they will tell you about having poor peeing, so they have difficulties in peeing, hesitancy, an interrupted stream, and their urinary retention. And as you can see in different epidemiological studies, have shown a prevalence as high as 24%, and these are in patients attending a urology clinic. So this isn't a rare exotic group. It's a real group that exists for which there are no clinical problems, no solutions to the cause. So some of them will have a cord injury, some of them will have peripheral neuropathy, some of them, there could be a primary bladder pathology, but a large percentage, it's all normal. There is no bladder pathology, there isn't a peripheral nerve problem. So is there some cryptic neurological lesion that's causing their underactive bladder? So, and often these people have associated sexual and bowel complaints as well. So the question therefore is there some pathology in their lumbosacral cord that's contributing or that's responsible for the underactive bladder? So this is sort of I would say is a clinical question that I throw back to you. And if you have the ability to collaborate with the urology unit, well, there's a protocol that's published. This is a virgin piece of work that needs to be done. And finally, moving on. So before over coffee, Marius has said how people have cracked sort of brain imaging. Now we've cracked sort of cord imaging. Now moving on to sort of the lumbar plexus and the lumbar nerves. And it's interesting that, which I hadn't actually been aware of, is that actually multiple sclerosis, peripheral root and peripheral nerve lesions are described. Demyelinating lesions have been shown in pathological studies. And so a piece of work that Marius and the team at Queen's Square MS Center are developing is imaging the lumbar roots and the sciatic nerve using high resolution sequences. And in some preliminary work they have shown the lesions in the sciatic nerve and the lumbar roots in patients with multiple sclerosis, just as preliminary work. But I think this is another area where the field can develop, because we know clinically that there are patients who have a lumbar plexus injury, but our routine resolution MRI sequences, lumbosacral plexus, are unable to detect these lesions. And I'm actually quite interested to apply this in this cohort of patients to see if we see more subtle abnormalities. The other group is diabetes, where you get sort of what's called diabetic amyotrophy, and patients have a very painful and a disabling sort of a lumbosacral plexitis, which sometimes isn't picked up in MRI, but clinically we know exists. Now, what it is that some of these patients, you think about immunosuppression because if it's an inflammatory mechanism, but we need evidence for that. And so knowing more about the pathology or what radiology said upon the pathology would actually be quite useful and have clinical applications. So in conclusion, I hope to be able to convince you that quantitative MRI, the lower spinal cord, is technically feasible, that we do have a landmark. We have as an intrinsic imaging biomarker, we have the lumbosacral enlargement, that we've moved a step forward, and it's not just the LSE, but even the more variable conus medullaris imaging. There is now a technique that's standardized and validated. We know that patients can tolerate this. So patients with MSA are often quite debilitated. They often have problems with breathing, problems with blood pressure, problems with the bladder, yet they were able to tolerate this without concerns. And so therefore, this can certainly be applied to patients who have less neurological symptoms. I think the applications is clearly MSA and other neurodegenerative conditions, multiple sclerosis, and also, and if you look at many of the neurodegenerative conditions such as Fragile X syndrome in adults, for example, or dementia with Lewy bodies, lumbosacral cord is affected, but also more urological conditions such as the underactive bladder. This is an area where this can be applied. And so I think there's a lot of potential in this, and I would hope that you go back and think about these collaborations with your urology or functional urology colleagues to see an area which I think is an area of urgent research. Thank you very much. I'd particularly like to thank the MS Society for the funding that they provided for the work that we've done. Thank you.
Any questions, anyone?
Yes.
Yes.
So thank you very much for your talk. People ask me sometimes about imaging spinal nerves and the DRGs and these things, and it's an area I've never done. But in your experiences, do you have like good reproducibility of these measurements in terms of maybe variability of the landmarks and the positioning of the slices? Like if you bring a patient back and image them twice in the same week, do you get roughly the same numbers? Because these are very, very small regions. And as you said, they're kind of floating and,
absolutely,
you know.
So I wouldn't be the right person to answer that question, but I think Marius, maybe from the preliminary work you've done so far, you might be able to give a flavor for that.
I mean, this is an area that we're looking at the moment, and the reproducibility of the measurements. We seem to be getting the coefficient of variation is almost acceptable. It's within the range of what we're used to. It's not much different, but I agree, it's a much more structure, and it's tricky to standardize the way of doing it between raters. So, but this is what we're looking at.
Are your voxels isotropic?
Yes.
Yeah. Okay. Thank you.
Yes, question there.
You compare to PD patients who are missing patients to try to see if it can help you with the disease?
So that's
so if you could
I'll repeat the question. So the question is, have we actually performed this in Parkinson's patients? And this is actually the next step, really, because if we want to take this forward marker in synucleinopathies, or particularly MSA, then that would be the next step. So that's sort of work in progress. Also, what we don't know is the changes over time, which is actually as important, because if you were to, several steps down, were to think about this as an imaging biomarker, you would want to know the rate of atrophy in this area, so that if you give an intervention with a neuroprotective to see if there's an alteration. So that, I think there are several avenues that we could actually now take it forward now that we've demonstrated this.
So,
yes.
So the measurements we can currently take from conus medullaris, for example, that would be just the area of the conus, or can you can segment gray matter, white matter from this?
So it'll be the volume of the conus, and it'll be, so I'm not the right person to speak, but I will, from what I understand, you image till you find that there's no more conus available. So then those last three segments where you see a bit of neural tissue, of conus is what you take. And because it's a cone, basically you can't take the mean of the three areas, so you have to take the volume. And what's been demonstrated is tissue-specific segmentation of the gray matter and the white matter.
But we wouldn't be able to tell where is S1, S2, S3.
No, and this is something that we've discussed hours and hours, and it's actually very difficult to say the segment. And this is why when we see conus, basically, if I understand correctly, everything below the LSE, basically, isn't it? Is what we're just taking. But we know clinically what we're seeing as a conus is going to be different radiologically, but it's the same area. And in conditions of MSA, we know that structures in what we call the epiconus is involved. So they have their blood pressure drops. They have a lax internal sphincter. So we know that the lower lumbar segments are also involved. But we can't precisely say that this is, because of the lack of landmarks, we're not able to say this is precisely the S1 or the S2 segment of the cord.
So along the line of this question, in the graph where you showed, so basically all the cross-sectional area that were centered at the enlargement, then you were showing the abscissa, the distance, like the slice number, and it went to like minus 56, 8, and so on. Is this abscissa normalized? So do you basically take look at the location of the enlargement for an individual, and then the location of the conus, and then you scale it across patients?
Yes, and I think Maya see
yeah, it's based on the number of slices per, because every person has a different length, so we kind of normalize.
Okay.
Based on the length or the number of slices.
Okay. Very cool. But so to follow up on that, is so what spinal level corresponds to the enlargement?
So T11 is where we start the imaging, because we know that that's the area of where the lumbosacral enlargement is. But of course, there's going to be some variability. This is why for each individual we have to, but we expect it to be at T11.
So T11 vertebral.
Yeah, vertebral spine.
Yes,
that's correct.
But then once you find the enlargement, what spinal level would that correspond to?
Oh, so that would be around T11.
So T11 vertebral.
Yeah, spine. Yeah.
Oh,
spine.
T11. Okay.
Yeah. So when I say spine, I meant the vertebra. Yeah. Yeah.
Okay. So T11
spine
at the
vertebra. Yeah. Which is where you have the lumbosacral enlargement.
Okay,
yeah.
Okay.
Should we invite Mark?
Thank you.
Yes. Okay, thank you for the invitation, Julian. Very kind of you to invite me. So I'm from this company, Synapse Systems, and I'm going to talk about the software which can be used for spinal cord assessment, atrophy assessment. And my disclosure is that the company is me. I'm the only employee and the only stockholder. So, so Jim is commercial. It's written in the Java programming language. It runs on these platforms: Linux, Apple, Mac, and Windows. It also runs on Solaris, but I don't know anybody who runs Solaris these days. So, and it's oriented towards clinical trials, really. It's used by a lot of research centers, but it was specifically designed to be used in clinical trials. So it has the background of sort of controls on software that are needed for clinical trials. It's a graphical user interface, but it's also command line driven, so you can script things and get things to run automatically. It comes with a Java programming API. So if you want to extend it, you can. And if you're a Java programmer, you can extend it with your own programs. And it's coming up to almost 20 years old now. Version 1 was released in 2001. So I'm going to specifically talk about one module, which is about the spinal cord segmentation, which came, the current release is version 8. This module came in version 6, 8 or so years ago, and it was a feature specifically requested by Rohit Bakshi in Harvard Medical School. He's got an interest in MS. He wanted a tool to assess spinal cord atrophy specifically for MS. But having said that, it's used in quite a few other centres, including at UCL, as we've just seen in the previous talk. So some of the, I mentioned it's specifically designed for use in clinical trials. And some of the features needed are that, well, first of all, it's got, if you're going to assess a group of patients, it's got to be applicable across the whole set of patients. One thing you have to try and avoid in that setting is to have a method which works for some patients but not for others. Requires some sort of intervention in one subset of patients that you don't apply to the others. Because you find that the ones it doesn't work for are the patients who move a lot, most disabled patients, the worst patients. So you're biasing your results if you don't take that into account. It has to be validated, and we've got validation studies. And the code has to be stable. In other words, if you run it in 2011, you would get the same answer that you get today. Now, because so it was specifically written for MS, because my collaborator was into MS. It has been used in other application areas, but MS is the group. And if you're going to segment the cord's fairly small. You really need sub-pixel accuracy. In other words, I didn't design it as a voxel-based segmentation where a voxel is either in the cord or out, but it's got sub-pixel accuracy because the cord's so small. As has already been mentioned, the ideal would be to have a fully automated method. It's not fully automated, but one of the goals was to minimize the amount of user interaction, which seems to result in a fairly low coefficient of variation, and has been shown to be sensitive to change as well. So it is able to measure atrophy, not just cord area. You can use it on range of contrast, but people use it mainly with T1 weighted imaging. It has been tried on T2 weighted imaging, but that's not generally what people do atrophy with. They use a 3D, either a head and neck scan or a dedicated cervical cord, 3D T1. And it didn't come out of the blue. It was strangely enough inspired by this study, which came, this method that came out of Queen Square quite a few years ago, 2002. This method produced what looked like nice results. It didn't seem to catch on though, for reasons which I've never fully understood, why it never got developed. Anybody look back? No? Right. So this is an active surface model, the original method published from Queen Square. The method you're going to hear about is also an active surface model, but it's a lot more compact parameterization. In other words, it's got fewer free parameters. And generally, if a model has fewer free parameters, it's more stable, it fits better, fits easier, it's more stable. And the particular parameterization allows you to impose smoothness. And one thing about the cord in MS certainly is that the cord is fairly smooth in outline, and it varies fairly slowly from the head downwards. It doesn't changes, but it changes in a smooth way. And is able to sufficiently model these changes, but impose smoothness on them as well. So the parameterization is simple. It has a center line, which is modeled as a smoothly varying polynomial function, and it has a cross-section, which the cross-section shape varies smoothly around the surface of the cord. Because of this simple parameterization, some things can't be modeled. For example, if you had a spinal cord that went up and down through the slices, this would be disallowed because both these functions are single value, and this slice has 3 centerline locations, so that's disallowed by the model. Similarly, the shape, the outline shape in cross-section is modeled as a function of the angle from the centroid position. So again, that single value function, but a shape like this would be disallowed because it has 3 radii of the cord. And because it's single value, you can only have 1 radius. So these are not usually problems in MS because the cord doesn't go like that in MS, zigzag out, and you don't get outline shapes that are indented like that. You might in other conditions, spinal cord injury, for example. Don't know, it might happen. But it doesn't seem to affect the usual MS patient. So the interactive steps, it's not completely automated. You do have to first of all reorient your cord to axial slices. So it's set up to run axially, and the software has a 3D multiplane reconstruction to allow you reorient the cord so that in the imaging slice, the cord appears in cross-section approximately. And the second step is you have to mark the center line of the cord. You can't, I've not come across I've not been able to implement a reliable method which picks out the cord. So you have to tell it where the cord is. And ideally you place a marker using the mouse on the center of the cord in sections roughly every 10 millimeters or so over the section of cord that you want to measure. And as we'll see later, you do have to get this marking fairly, not spot on, but it helps if it's right in the middle of the cord for reproducibility. So the cord's initialized, so there's the marker, it's initialized as a cylinder, and then the model causes the cord shape to evolve. The surface of the cylinder is updated according to gradient information, and the center line of the cord is updated according to the location of the centroids of these cross sections. Now, one thing that's perhaps not appreciated is that the model only, in order to update the model, it only uses gradient information. So the outline shape is attracted towards edges. And it doesn't use intensity information, it just uses gradient information. And the advantage of that is it's pretty much immune to inhomogeneity the MRI scan. You don't have to do an inhomogeneity correction before you run the scan. As long as it's fairly inhomogeneous over the cross-section, it'll still work fine. And since this distance is only 10 millimeters or so, 10, 15 millimeters, then the inhomogeneity over 10 or 15 millimeters is also very, very small. So you don't have to do any pre-processing other than reorienting to axial. Now, the smoothness constraints are done using Fourier and least squares method, which I'll talk about in a second. So the smoothing of the surface, the smoothness is constrained to be a smooth outline, smooth cross-section of the cord, and it's also constrained to be smooth transitions down the cord, transitions in shape. So the way this is done, imagine this is a few cross-sections down the cord. This outline shape is parameterized by a function of the radius. The radius is a function of the angle around the cord. So you can transform this into radius versus theta around from the centroid. that can be considered a periodic function. So if we Fourier transform that, we get a spectrum of frequencies from this radius function. And then the smoothness of the outline is maintained by zeroing some of the high frequency components of this spectrum. So you can see that some little ripples here, which have been suppressed. So the coefficients are eventually just set to 0. And then down the chord, these coefficients, if you imagine, for example, this coefficient varies down the chord. There's then a least squares fit these coefficients to provide some smoothing down the chord. So that constrains the shape to vary smoothly down the chord. Having done that smoothing step, you then do an inverse Fourier transform to get back to the outline shape. So the smoothing is done in Fourier space, and the smoothing of the coefficients is done using a least squares polynomial fit, the spectral coefficients of the shape. So the total processing time is around about, including the reorientation and marking of the chord, setting going, probably takes 5 or 6 minutes or so to process one subject. So this just shows the evolution from the initial marker to the initial, it's modeled initially as a cylinder down the chord, and then the shape is updated by its attraction to the gradient. It's attracted towards steep gradients. And I think this just shows it in 3D. Yeah. So how reproducible is it? Well, this was the initial reproducibility study, which was simply an intra-observer and inter-observer variability study. And we did it over, first of all, I think it's a 3 mm section of the C2-C3 junction, giving reproducibilities of around 0.6 for intra and 1.3 for inter-observer variability. And if you do it over an extended section of chord, C2 to C5, they drop to less than 0.5% or around about 1% for inter-observer variability. And this was done with some fairly old data. This was a almost isotropic NP radiant for the spical chord at 1.5 Tesla. So there's been a few other studies, not done by me really. I've not really been involved, but this one showed. So this one from Queen Square. This one showed variability at 3 Tesla with 2 different sequences. Again, at gradient echo, inversion recovery, showing again quite good reproducibilities. This time they did a scan-v-scan study, which I suppose is the most representative, showing at 3 Tesla isotropic resolution, you get reproducibility of about 0.5%. And using this inversion recovery, they quite remarkably got down to 0.1%. But I've never seen that bettered. I'm not sure. Well, clearly it's a real value, but I've never managed to get as good as that. Another one done with just a short section, a really high in-plane resolution, but quite a thick slice. So you can get away with quite thick slices because the chord doesn't vary much in the craniocaudal direction. So they did, if I remember right, this was 3 slices, 5 mm thick, and again, getting inter-observer variabilities of less than 0.5%. Again, a 3T study using different pulse sequences. So this was a comparison of different pulse sequences, some 2Ds and then a 3D, and across different 3 Tesla scanners. And I haven't put all the details in, but really, depending on the pulse sequence, And I think the 3D gradient echo came out best. They were getting less than 1%. I think in this degree, if I remember right, the 3D gradient echo came out best, and the 2Ds weren't quite so good. So the 2.38 would be the inter-scanner variability between different manufacturers. So having looked at a few studies over the last few days, a few patterns come out. First of all, 3T is better than 1.5T, as you'd expect. So the higher signal to noise, better resolution. Measuring over an extended region is better than at a single disc level. All the old atrophy studies were done at C2, C3 junction. But if you can do C2 to C5, or even perhaps a bit longer, you're going to get better reproducibility, COV. It would seem that higher in-plane resolution and thicker slices, or in 3D, a lower through-plane resolution is going to give you better results, as you'd expect, because the chord doesn't vary much in the superior inferior direction. But I think, as with all studies, it's important, if you're going to do a clinical trial, it's important to use the same scanner and, as far as possible, the same sequence for the whole duration of the trial. And that's not just for chord studies, that's for brain. And it would seem, if you stick to this, you should be able to get a scan-rescan COV of around 0.5 to 1%. It would seem to be quite hard, no matter what you do, to get better than that. So it has been used in other, I've seen it used in other diseases, for example, motor neuron disease, spinal cord injury, but it was designed for, and its main application is MS. So it's now getting on for 10 years old. Now it has changed a little bit, but not very much over the years. And I'm thinking about improvements for the next release of the software. And one of the things is that it is sensitive to the position of the markers. You do have to be careful when you're placing the markers. If you do it carelessly, you get bad results. This is slightly exaggerated, but if you shift the marker off center, you get, first of all, slightly wonky chord outlines, and then it just goes absolutely haywire. So it would be nice to, even if I can't get fully automated marker positioning, it would be nice to make it less sensitive to this, and that's already achieved in the next release. As I said, ideally for clinical trials, whatever method has to be completely reliable. Otherwise, you risk biasing the data against the patients who are most disabled, less able to keep still, that sort of thing. Or indeed, the people with really atrophied cords and poor quality data. It's also a cross-sectional method, so it measures the chord cross-sectionally, obviously, because you cross-sections of the chord. What I mean is it measures the chord area, the chord volume at one time point. And if you want to look at atrophy, you have to measure it at one time point and then at another time point. And there are more advanced ways of dealing with 2 time points, or more than 2. So you take advantage of similar information across time points and look for differences in information across time points. In other words, you can standardize using the patient as their own control. There are ways to take advantage of the longitudinal aspects, which I'm also, I think that sort of work's going on at Queen Square, and we're also looking into that as well. So I'll finish there and say thanks to my collaborators, especially Professor Bakshi in Harvard and Dr. Nima, who works with that group, who came with the request for this method, and my collaborators in Milan who supplied me with a lot of data, first of all, and a lot of ideas for this work. Thank you very much.
Thank you for that. We have time for a few questions.
Yeah.
In the segmentation, do you ever, or do you even think it's wise to assume any sort of symmetry of the cord to try to help you better place that point right in the center?
Could you please repeat that? The question was, should we consider symmetry of the cord? First of all, perhaps to help place the centroid, the marker at the center better. But I think also from that, also you could get a better segment. If the cord were symmetric, you could use that information. For example, it's done in Fourier space. If you cut out some of the coefficients, you can force the cord to be symmetric. And yes, I have thought about that. One problem I've seen is that if you have pathology in the cord, that is asymmetric generally, so that could upset the symmetry. But I've also seen that you could keep the cord symmetric, but the cord does twist sometimes as it goes down the spinal canal. Not by very much, but maybe 5–10 degrees, you see some twist of the cord. So yes, it could be symmetric, but you'd also have to allow in the model for it to twist. But you're right, if you can impose symmetry, it helps with the segmentation, obviously. It might not be so good then if you apply to things like spinal cord injury. You would have to have one that allows symmetry and one segmentation that imposes symmetry, which is not a problem, but yeah, it's a good idea. I think so, yeah.
You mentioned that some of the results are very sensitive to where you place the landmarks for the center.
What I mean by that is sometimes I get users who first try it. So I didn't let you finish your question, but I'll just say the question was about how carefully you need to place the markers, the landmarks.
Yeah.
And initially, some of the users try it out and they say it doesn't work. And then I ask them to send me their image and their markers. And all they've done is place the marker somewhere in the cord. And as soon as they start marking, so you zoom in, mark carefully in the center where you think the center of the cord is, then it works.
My question was just how this affects the results that you showed of the coefficient of variance that you showed is quite nice.
Yeah.
Did you
so
remove these points from the data set where the temperature of the place were?
So quite recently for that initial validation study, so the question was, how is the COV being affected by how carefully the markers are placed? So that initial validation study, which I showed, which we did, I went back fairly recently and looked at some of the markers, and they weren't very well placed. So I would suggest that if the markers had been really quality controlled, the COV would be at least as good as that. So what tended to happen, what I saw was that maybe at the extremes upper end or the extreme lower, they perhaps got a bit bored with placing markers, and one marker was out of place, and it really affected the cord outline in that region. But the rest of the cord was fine. So I suspect that the COV could be better than that. And that might explain why there was one study where the COV was really remarkably good, and that was done in a really high res in plane, thick slice. And I think the contrast in that scan was really good. The spatial resolution is really good, and therefore it's easy to place. Yeah.
It's fairly obvious in initial review if you haven't marked it very well. Just as it becomes and then one place that would like that and you'll have to do it again. So it hasn't worked. Very obvious.
So I'll just repeat that. So just before Almudena if she wants to say anything. So the comment was that if you mark badly and you then review the shape of the spinal cord, so page through the slices, looking at the shape, it's immediately obvious, like in that example I showed, that the marking is bad because the shape is bad. I think it's fair to say, Dave, comment, that if the marking is good, the shape of the outline is always good. He's nodding.
Yes, just to add that when the substance of the plates correctly and mistake is, as you mentioned, is very, very obvious. And it's easy to correct.
Yeah, can I ask a question that doesn't involve the marker?
If you can think of one.
Yeah, I can. Actually, I really like the polar coordinate representation. I thought that was really quite cool. Now, is that under the hood, or does that stuff actually get outputted at the end? Because that actually provides information. Like your cross-sectional area is just the circular integral of that. So that's actually kind of cool.
So, yeah, what's internally represented is the chord outline in polar coordinates. Yeah. What's output is the chord outline in XY coordinates. So if for example, you don't like the shape,
right,
you can manually intervene and drag those points to where you think the edge is.
Right.
I'm not recommending you do that.
Right.
I would recommend you adjust something beforehand and get it to output properly.
Has that been used by any of the people? Because that would suggest that you could figure out, in cases of atrophy, where the atrophies occur. It's more ventral, more dorsal.
Paola, I believe, is going to speak on exactly that subject. Is that right, Paola? You're going to mention about where atrophy occurs tomorrow?
Okay.
Yeah. So Paola is one of my collaborators in Milan, yeah, and she's used this as the basis for further exploratory work on exactly that subject.
Okay, cool. Thank you.
I can comment further on putting markers.
No, you can't, because the question wasn't about markers.
Because I have put a lot of markers. So, in my experience, if the placement of markers is reasonable, all the outlines are moved, and there is not that difference in the mean cross-sectional area that is produced if you are very careful in putting marker exactly at the center line or in the but I saw a difference in the quality of straightening the coordinates that are used for the regional analysis. So when you straighten the coordinate and the initial estimate of chord marker centroid was not that precise, the quality of straightening is sometimes not perfect, but
so perhaps I should mention, one of the handy things about this parametric model is that one of the parameters is the centerline path. Mm-hmm. And that means that you get a very straightforward transform to get the straightened chord image out. It's sort of for free. No extra processing is involved. But there's a sort of a squared distance penalty imposed on, which helps to keep the chord center line close to the center line. It's not constrained to be at the centroid, but there's a least squares penalty if it deviates from the centroid. And as I think as Paola said, that's the cause. Bad marking has a tendency to pull the center line away from where it should be. Not by much, but a bit. Anyway, it would be nice to make it less sensitive to that, and that's something we're working on.
Okay, if there are no more questions.
Ugo.
Yeah. Sorry. I like the Fourier space applying of the smoothing, but I was just wondering, you said you were zeroing the high frequency components. Do you do that by some kind of, I don't know, Butterworth filter or something like that?
No, they're just set to zero.
They're just
set to zero. Nothing fancy.
Function. Yeah. Does that
so you
any kind of artifacts in your?
No, it doesn't seem to.
Because in other applications you try to avoid that. edge in the filter, right? So I was just wondering about that.
So one thing I didn't mention is you as part of the input, you can choose how many Fourier coefficients you want to save. And the more you save, the wobblier it can get. And for example, if you only want to use one, you're constraining it to be a cylindrical tube, which is not much use. But surprisingly, you can get a really nice chord shape outline with just 6 or 8 coefficients. It looks like a chord. I've never thought about it before, but I've never noticed any artifacts caused by just by doing nothing clever except zeroing the coefficients. There might be a reason for that, but that doesn't spring to mind at the moment. But let me think about it.
That's a fairly smooth function of angle, isn't it?
It is, yeah, it is. So the more you increase the number of coefficients, the wobblier, and the more chances it has to go wrong.
Yeah.
So you want enough coefficients to build shape, but not too many that you don't need them.
Okay, shall we move on to the next speaker? Questions. Thank you.
Okay, thank you.
My pleasure to introduce Hugo Brenken from VUMC in Amsterdam, who is going to talk about upper cervical cord atrophy in MS.
In the dark, right here, where they can see me. Yes. Okay. Thanks for the introduction, and thanks very much to the organizers for inviting me. It's a great pleasure to be here. I am actually now from the Amsterdam UMC, which is the joint academic hospital in Amsterdam after our two previous entities are merging now. So no longer VUMC, but Amsterdam UMC is the name. And I'm going to talk about upper cervical cord atrophy in MS. I do have a few disclosures. Let's show them to you. So I'll talk a little bit about the clinical relevance and the mechanism behind upper cervical cord atrophy in MS, and then mainly talk about the measurement. Marcus very nicely covered the technical details of Jim, and I'll talk a little bit about comparing different methods and influences on the measured values. So, yeah. So we have a very nice monitor here that you can use to see your slides, but then I don't stand in view of the camera, so I don't know if that is.
You can turn a little bit.
So as not to look over my shoulder. All right. So just to talk about the occurrence of cord atrophy in MS, a study that was done in Amsterdam, initiated by Frederick a while ago, looked at long-standing MS in a very large cohort and saw that if you look cross-sectionally at one time point, you see a reduction of the cord cross-sectional area, which was also associated with the clinical disease, and was also associated with spinal cord lesions, suggesting that, are these is this a mechanistic association, or is this perhaps unrelated and just both occur as the disease progresses? So we want to understand that. Another thing, but I won't go into much detail because Paolo will be talking about this tomorrow, but that has been mentioned already, is that there is some distribution also along the cord that you may want to study and try to understand the disease. I think very interesting. So that adds to the importance as well. And then this was cross-sectional, what happens over time. If you look over time, the cord degenerates further, and there are again these. I love this figure, by the way, but you have to zoom in really to this bottom lower part, so I did that for you, which I think is for the longitudinal part the most telling piece, which shows the change. So this is the left part, this is the difference without the controls in colors. But here in the right part, it actually represents the difference between baseline and follow-up as a percentage. And you can see how in early MS, it's mostly in the upper part, whereas in later progressive MS, it goes to the lower part of the cervical cord where the change is fastest. So these are very interesting observations that we need to address further. then if you look at the cord as a whole, which is more from a trial or clinical perspective, it could be more interesting to look at the average change of the cord cross section across the whole region. I won't talk about this in detail because my colleague Professor Barkov will speak about that later, and I don't want to get on his bad side. So I will keep this very brief, but this is just to say that there is this change. You can measure it even at 1 year. It changes and it's detectable, leading to sample sizes that are reasonable for trials. Then one other paper that I came across that was published not last year but the year before by the Barcelona group looked at early change of cord cross-sectional area over a 2-year period and found that this predicted the subsequent EDSS change at 14 years, which I thought was remarkable that this is such a prognostic value. And they looked at this at different cord levels. This is why you see these different figures, but it's very consistent and very interesting in terms of prognostic value. So we have reduced cord area in the upper cervical cord. When we scan an MS patient, loss is progressive over time. There's a certain anatomical distribution that we like to understand, and the rate of change also has even prognostic value. So that's enough reason, I think, to study this and work on methods to measure cord atrophy in the upper cervical region accurately. But we do have to think also about the mechanism. So how does this come about? The precise mechanism is not clear. It could be a primary degenerative process, even in the, especially in the gray matter, but maybe also in the white matter. Potentially secondary to lesions, as we have seen also in the brain. So we need accurate measurements to study these effects and understand also the mechanism. So we want to measure the cord area in the presence of lesions in MS without any influence of those lesions. And ideally also those measures should be applicable in large patient cohorts or in a clinical setting to accumulate large numbers of patients to understand these effects and to be able to apply them as measures in trials. So cervical cord imaging is very nice and gives you a lot of information, but it also takes a lot of time, which costs money. At least where I work, we have to pay for all our scans from our project funds, so we have to think carefully about how much time we use. And from a clinical perspective, it has this kind of 3D 2:1 image of the cervical cord, has limited added value beyond this measurement of cord area that we are interested in. So then at some point, we asked ourselves, I think at the suggestion of Frederick a couple of years ago, so why don't we measure the upper cervical cord atrophy from an MRI of the head rather than of the cervical cord. So then we looked at that together with Karsten Lucas from Bochum and Barbara Bellenberg, who's sitting over there. And so we looked at differences between different disease groups. And I should mention, this was a very large cohort. That's a very good thing. The bad thing is we didn't have any healthy controls because it was only patients. So the only thing we could look at in this sort of retrospective analysis of this cohort data set was differences between disease types. So you have relapsing remitting, secondary progressive, and primary progressive. And then the two colors I should point out here are the two different centers that contributed to this study, Basel and Amsterdam. So what were the results? Well, you've seen it here already. Both of the progressive disease types had lower upper cervical cord cross-sectional area than the relapsing remitting patients. And they find the abbreviation here, MACA, that we came up with at some point, and you can work out perhaps how the letters work. It doesn't really work because there are too many C's here, but we're just going to leave it. So we saw these differences between the progressive and non-progressive type and found them in both centers. And then we went on and looked at the longitudinal data for this cohort. And of course, you lose a few patients. There are a few fewer patients here than in the previous slide, but still a large cohort. And you see this trend of decreasing spinal cord cross-sectional area for all the disease types. And here I should point out the colors indicate, or the gray values indicate the time points rather than the centers. And the centers are lumped together. So all disease types showed this progressive loss over time, except for the PPMS in the second year, which could be possibly related to the small group size. I don't know. So this is really a story about how not to do things when you do science. So first we did all these clinical studies, and then we said, well, let's validate the way we measured the MUCA from the head scans. Is that really, I mean, was that valid? So to remind you of the rationales of why do we use head 3D-T1, of course, in a lot of studies we do have these images, and we don't have the cervical imaging. So we have a potential for studying large groups, also retrospectively, like we did in that work that I just showed. And it also has a much bigger potential application for clinical use and clinical trials. So the research question was, can we reliably measure MUCA from head 3D-T1? And in this case, I think for once we were able to say, yes, we can, which about 12 years ago was a big phrase, and then in the Obama era. But we were really happy to say that, and I was really proud, in fact, that we got this scatter plot, because I've never seen a scatter plot like this in my work. Never been able to forge the data quite in this way. So here you see the sort of the ground truth spinal cord imaging-based MUCA value, and then here the brain or head 3D-T1 based value, and in the symbols indicate the centers and the colors indicate the disease types. I don't know if you can see that, but across 3 centers and 4 different clinical groups, so healthy controls and 3 patient groups, this was very consistently associated. So we were very happy with that. And this was done with the NeuroQLab software that was developed actually at the request of Karsten Lucas. Quite a sort of similar story to what you were saying about Professor Bashki. Somebody had a clinical question and asked a friend if they could develop it. So we looked at that software here, and we did head and cervical imaging on all these people and compared them, and the result is as you see here. And also when you look at the Bland-Altman plot, you see there's no discernible bias or anything. So does that answer the question? Well, I already said this was only one software. So what about other software? And also what about differences between scanners? You know, if you move a patient to a different scanner, what happens, or if you change the protocol? So we started to look at that again together with Karsten Lucas. And I'm going to be using a few slides that he kindly sent me. Where the aim was to improve multi-center studies using this MUCA measure as an outcome measure. And this was all done in the context of the MAGNIMS study group. So the first part of this study, and the part that I can talk about now, is about a single healthy volunteer, someone from Bochum named Karsten Lucas, who traveled between various sites and then underwent a scan, a repeat scan, and a full repositioning rescan, including head and cervical 3D-T1. So that's what that looked like. So each run included identical brain and spinal cord sequence shown here at the bottom. So the first run, a repeat scan, and then goes out of the scanner and goes back in again. So that gives you a very nice data set to look at these differences. And then the cross-sectional area was measured at different cord levels, and I really like the way that Karsten has visualized this here as a 3D representation. So we have the C1, C2 range, the whole cord C1 to C7, obviously only from the cord imaging, and then sort of a single slice at the C2, C3 level, intervertebral disc level. So we have these different levels, and we also have different software, GYM, of course, NeuroQLab, also Spinal Cord Toolbox. I think these are obvious, and then In the future iteration where we look also at the longitudinal change, we'll also be using this GBSI measure that will be discussed later, I'm sure. So there are some differences between software. For some reason, SCT seems to give lower values for the MACA than the other two software, irrespective of the location, it seems. And there are also differences between, of course, the anatomical levels. One thing that's already been mentioned, if you take a larger region, you're probably going to be better able to measure the average cross-sectional area, especially in a structure that's so smoothly varying along its length. And that, I'm sorry, I meant to say that also differs between softwares, how much variability there is across measurement levels. And then there was also variability between sites. I apologize for the fairly poor quality of these figures. But here you see in the colors the different sites. And here you see two different levels, the C2, C3, and C1 to C2 length measured. And you see a lot of variability. Of course, these are box plots based on 3 measurements, so you have to take them a little bit with a pinch of salt, I think. But it does show variability in a single healthy control. Reproducibility across the sites was limited. The best detection limits or the lowest variability was observed for the whole cord measurement. Again, not surprising because you have a fairly smooth structure. So the average is going to be best if you have a lot of measurements. So the strengths of this study then were that we have the head and cervical imaging. We are going to make the data publicly available as a single subject, similar to the one data set that Julien mentioned, I think. Limitations then are that it's only a single healthy control, and there is a time between the acquisitions on this person because he traveled, and also he didn't travel the next day. Maybe he traveled after a few months. So there is some, there could be some physiological variability in the cord itself. So to address this, we set up another study. And also to look at how this looks in MS patients, because here we had a healthy control, we didn't have any patients. And another question that we had is what about lesions? Because of course in MS we have lesions. And we know from brain atrophy measurements that often these can influence the methods that we use to quantify volumes or cortical thickness or whatever. So what about the cord? So to address these two questions, we did a study in Amsterdam, but also again with collaboration from Bob, where we studied 2 data sets. This was recently published in the fall Neuroimage Clinical. 2 data sets, one to look at the variability within and between scanners, where we had 21 patients and 6 healthy controls who underwent the same day rescan on all of our three Tesla scanners. So they were scanned twice on each of those 3 scanners, so 6 scans in total. Quite challenging for MS patients. Some of them were progressive, so I'm very happy that they wanted to contribute. And then the second data set we used to study the effect of cervical cord lesions, where we took patients from a different cohort, and for historical reasons, this is also a number of 21, but it's a completely different patient set from the other data set, so it's a different set of patients. So we selected them from a larger cohort, actually the cohort that I mentioned before from the Daams paper on long-standing MS. And then we selected patients who had a lot of lesions and patients who had no lesions, and then compared them. And they were balanced for sex, EDSS, and also the previously measured MACA to rule out any such effects, because we're not interested in disease, but we're interested in measurement accuracy. And there we had, in fact, dedicated cervical cord imaging, whereas in the first data set we only had head scans, which I meant to list here, but I forgot, I'm sorry. So these are head scans. I think it's in the next slide. And then again, we had different softwares, the 2 SCT modules, PropSec and DeepSec, GIM, EuroQLab, and as a 5th one, ITK Snap, which is a semi-automated tool. So what were the results? results were that the measurement of upper cord atrophy does vary across scanners and software. So here you see some examples. This is the original image. Here you see the outcome of SCT PropSec and DeepSec, GIM and ITK Snap. You can already see some differences in the outlines, and here again we see in yellow the DeepSec gave us low cord cross-sectional areas, low MACA values. PropSec was higher, and so were the others. What you see here in the full and shaded color bars are the scan and rescan values, and that's quantified a little bit further here, showing that regardless actually of the software, except for the ITK Snap, which is really semi-automated, slightly higher, slightly lower ICC values. All of them were, absolute agreement above 0.99, which is very high, almost all of them. Regardless of the scanner and the software. So that's, I think, very good news. For a full rescan that you get such good reproducibility with low coefficients of variation. This is in percent. So that's good. And then we also looked at the segmentations that were generated. So these colored structures, how well do they overlap between the scan and the rescan? We calculated dice similarity indices, and these were also very high. They go up to 1 for perfect agreement. And I think these are very, very high in this kind of context and for the study design that we used. So this is good news. So we have a very high ICC, low coefficient of variation, and also a very good agreement, not just between the cross-sectional areas, but between the segmentations themselves. So it's very reproducible. Then, what about the differences between scanners and between software? What we found here is that for the specific imaging protocols that we used, the MACA values measured at the GE were always lower than those measured at Philips and Toshiba for any software, regardless. Then Philips and Toshiba are very similar, except for the DeepSec, where even there it's actually difficult to see the difference by eye, but it was significant. And then take your pick of software and stick to it, because if you're going to use another software, you're going to find a different result. Is basically what we found. MACA from any software is different from MACA from any other software, except for the specific case of NeuroQLab and GIM on Philips or Toshiba. And that's what you see here, I guess, in the blue and purple. They're always very close together for Philips and Toshiba, and so they were not different. But in general, these were always different if you change software. Then, there shouldn't be an exclamation mark, there should be a question mark. Is MACA measurement affected by MS lesions? This happens when you make last minute adjustments to a slide. Yeah, so this should be a question, and then I'll give you the answer. So is it affected by lesions? So we had these 21 patients that I mentioned before, 14 patients with a lot of lesions. This was actually a lot of work because it was an old data set, and then the student who did all the manual work, let's say, checked whether the lesions were present, but he didn't label them, so we couldn't retrieve it. And then the PhD student went through all the images again and confirmed that indeed in the sections that we were measuring there were lesions. So this was extensively confirmed that there were indeed visible lesions in the T2. And then 7 patients without those lesions, and we compared how well the MACA measurements worked. So here we have the absolute and consistency measures of ICC. You will see that depending on the software, the values get slightly higher, but absolute agreement is very poor across the board. So if you look at consistency, it gets better, especially for GIM, NeuroQLab, without lesions, and also with lesions. And there doesn't seem to be much of a difference. And then when you look at the DICE similarity index between the automated segmentation and the manual segmentation that we made as a reference, you can see that there is no systematic worsening of the DICE in the presence of lesions. In fact, if anything, the boxes for the lesions group seem to be higher than the other group. So we cannot, for any of these software, detect a difference between the many lesions and no lesions group. So we concluded MRI measurement and segmentation accuracy were not affected by the MS lesions for any of the software studied here. So to conclude, upper cervical cord atrophy is important in MS, is a potential outcome measure for trials, correlated to clinical decline. The rate of change has a prognostic value in the long term for disability. The MACA, as measured from a head 3D to 1, could be an accessible biomarker in many studies. Very closely related to the cervical 3D to 1 measurement. It's very good within scanner reproducibility. It does have some drawbacks, which is that there are substantial differences between software, but I guess that happens in many fields, so that's no surprise. And then sadly, there are also some differences between scanners, but again, in our field, we know that this happens all the time, so I guess we have to work like Julien's initiative on harmonizing protocols and try to minimize such differences. And finally, there was no detectable influence of cervical cord lesions, which I think is a very good thing because it allows us to measure these aspects of the disease independently without worrying about the influence of lesions on the cord atrophy measure. I just want to thank my collaborators, my group, and abroad. Thank you for your attention.
Any questions?
Very nice study. So I just wanted to basically add a comment on the inter-software difference. As you mentioned, there are differences. I just wanted to add some details like about the origin of those differences, which I think is important to note. Is that like GYM and PropSeg are based on like gradient-based approaches, and there's really an arbitrary decision as to what is the threshold for this gradient, right? Yeah. And so there was no agreement between the GYM and PropSeg and ITK-SNAP about where to set this gradient. And so for SCT, we decided to be a bit more conservative about being inside the spinal cord for template-based registration and analysis. But as you mentioned, the important aspect is to really stick to a software. And I would also add to a software version, because software also evolves in time, so it's very important.
And hardware, operating system, etc.
Yeah. So when studies are published, to make sure that the software version is the same.
Yeah. Should I repeat that comment for the people who are following this online?
I try to speak loud, so I think they got it.
Do we actually have to consider variations of volumes in the spinal cords as well as we do in the brain by the time of the day or the season where we image these patients based on the water content?
Yeah, so I'm going to repeat that question now. Right? Maybe it was loud enough. So the question is, was that, do we have to worry about, let me rephrase, physiological or other variations of the volume of the cord, right? Depending on time of day or other factors. And I think in principle, yes. I mean, why wouldn't we? But I'm not aware of data that has studied that. It could be out there. Maybe other people here know.
There was a study done of dehydration effect on cord volume, cord area, done in Vancouver, I think, 2 or 3 years ago.
Right.
And they saw not a strong effect, but the order of 1% dehydration state.
Okay, so there's a study from Vancouver that detected a 1% order effect on the volume. Yeah, depending on hydration status. Yeah. Was it that study that did like the, I don't know, 24-hour or something, a very long period without taking fluids?
Yeah, it was.
Because I know a paper on the brain atrophy effects, but.
Yeah, I think it was done over 24 hours. So it was from fully hydrated to
more than 12 hours later without fluid.
Yeah.
And I think it was maybe a little bit less than 1%.
Great. So yeah, apparently there is some data showing that it has a substantial effect. Yeah. Yeah.
It seems that this term MACA, it can refer to actually like different parameters you can actually get from the image. So it can be the area at the level of the disk between C2 and C3, or it could be average over a certain region. Would you like potentially use it as a discriminator between diseases? Is there any particular way of measuring it that would be better than other measurements? Like, for example, that would correlate better with disability or something like that.
Yeah, so the question is regarding the levels at which, or the length along which you measure, what choice do you recommend to distinguish between diseases? Is that correctly
if you want to use MACA as a discriminator between diseases that affect spinal cord,
yeah,
what way of measuring MACA would you recommend? Would it be at the level of the disc between C2 and C3, or would it be average over C1 and C2, or C2 and C3, or how would you do it?
Two answers to that question. The quick answer is that from the data that we have now, I would say you have to do cervical cord imaging and measure along the whole length of the cord and take the average, because that gives you the lowest measurement variability. But we're also studying, in that Magnum study, we're also studying the discriminating power between MS and controls and measuring the change over time. And then perhaps you can find that if your technique is sensitive enough, you don't have to image the whole cord and you can do it with a smaller section. I don't know yet. No.
Can you go back to the slide?
Yeah, I think so. I hope so.
No, that's what's good. Can you come up like just this one?
Yeah.
Okay, it seems that for the group with no lesion, the variability is always higher than for the group with many lesions.
Yeah.
Can you comment on that?
Yeah.
French, actually.
Yeah, but those are 7 patients, and yeah. Oh, sorry. Very good. Thank you, Julien. So the question is, why is the variability higher in this no lesion group compared to the many lesion group, right? So I think the answer is mainly this is 7 patients and this is 14 patients, and it's a very skewed distribution because this is the maximum one, which you are unlikely to ever find in this study. But you're still very close. I guess that's what explains it. But yeah, if anyone has a clever idea why this is the case.
Yeah, just like a quick question/comment on the MACA index. So all that was vertebral based, right? So maybe to come back to the debate about spinal based, levels. Have you looked into looking at your level based on the frontomedullary junction or other spinal based level?
We have used SCT to find levels, to determine the vertebral levels. But then, because for the head scans, that was very tricky to get it to work, right? For this study, we pre-selected a certain region and compared just the segmentations in that region across all the software.
Right.
So we did that manually, basically.
Yeah, but the question was more of finding a level that is not based on the vertebra on the spine, but on the like either like the bottom of the brainstem or the frontomedullary junction, something that is really independent from the spine.
Yeah, no,
because the spinal cord moves. The people move the head.
Yeah.
The spinal cord moves, but not
independently
from the spine. Maybe that's something
interesting point.
That could possibly reduce the variability across time.
Yeah. Interesting point.
I'm just curious, what's actually driving the MUCA, the atrophy? Is it changes in the cervical cord primarily, or is it brain changes? In one of your slides, you showed that there was a volume loss in the cord with regions of the brain.
Yeah.
So could this all be just changes as a consequence of pathology in support of white matter changes?
Could be. We're going to do a study now where the same PhD student, she collected a lot of data longitudinally on using an extensive protocol on 40 patients and some health controls. Mainly focused on the brain, but she also acquired cervical images. And we're going to be looking at how that relates over time. Yeah, maybe next year I can give you the answers. I don't know.
Okay, it seems like we should close this session now. Thank you very much.
Okay, we do the break here. There is the coffee stories across UCL. Is the second room that we are visiting. Tomorrow another meal. Okay, different layout, I promise. This is the second session today. Becky and Marco are going to be the chairs. And well, you can introduce the speaker.
Okay, so welcome to the second session. And so first of all, we'd like to welcome John Ashburner, who is going to talk to us about extending SPM for the analysis of images of the head and neck.
Okay, well, thank you very much. So the talk will be about our efforts to extend tissue probability maps within the SPM framework to enable the joint spatial normalization and segmentation of the brain and spinal cord simultaneously. So they can both be analyzed within the SPM framework at the same time. But to begin with, I'll talk about the existing framework that we have in SPM, because I'm sure most people here are SPM users. So the existing segmentation, which combines nonlinear alignment of images with tissue segmentation and intensity non-uniformity, has been in the SPM code for quite a while now. So I'll just go through what it does. So the basic method was described in a 2005 paper, and it's based around a Gaussian mixture model for modeling the intensities of different tissue types. So, for example, if we have a pair of images of different MR contrasts, we can compute a joint intensity histogram between the two images, and we can fit Gaussian distributions to this joint intensity histogram. And the idea is that each of these Gaussians shows intensities that belong to a particular tissue type. And we can actually show that the probability density encoded by those mixtures of Gaussians. So methodologists might express this kind of a model like this. So every pixel is encoded by a label that indicates which tissue class it comes from. And then there's a mean and a covariance that describes the intensity distribution of each particular tissue class. And then there's the mixing proportions that says what proportion of pixels or voxels should come from each of the K classes. But the basic model is extended slightly. So MR images can be corrupted with a smooth intensity non-uniformity. So those using software from Montreal might run N3 or N4 on the data to do bias correction. Within the SPM framework, this bias correction is incorporated within the segmentation approach. So if we plot a histogram of the intensities of the uncorrected T1 weighted image here, and the intensities of the corrected T1 weighted image, you can see that with the bias correction, you get a better separation between the intensities of white matter, gray matter, and other tissue classes. So before bias correction, there's quite a lot of overlap. After bias correction, there's less overlap. And it works with multi-channel data as well. So uncorrected, corrected, the differences are very subtle, but it changes the joint intensity histogram of the images. And enables a better separation of tissue types according to the voxel intensities. So going back to that graphical representation of the model, there's now a vector of alpha parameters that encodes some kind of smooth non-uniformity intensity with some kind of regularization on the alpha values. And this is the kind of combined segmentation and bias correction model. But also we know where to expect particular tissue types within the brain. So we can model where we expect the different tissue types with tissue priors. So these are the tissue priors and resulting segmentation. So the idea here is that we deform a set of tissue probability maps which would be overlaid onto the image that we want to segment, and that helps inform the segmentation of tissue types. So the effort has been on trying to extend this set of tissue probability maps. So if you're using software from Montreal or various other places, they tend to have tissue probability maps for grey matter, white matter, CSF, but there's nothing else. So it doesn't represent anything else in the head. So we wanted to extend these tissue maps, both in terms of the types of tissues encoded in MRI scans, not just the brain, MRI scans of the head, so that we have coverage of the brain and a bit more of the spinal cord. And there's also a few other parameters for kind of scaling slightly the tissue probability maps to account for the kind of global atrophy, for example, where there might be global less grey matter with a bit more CSF and so on. So there's some other parameters in the model that can account for that kind of thing. So the model with the deformable tissue priors is basically we've got a set of tissue priors and we've got some parameters that encode how those tissue priors need to be warped for individual subjects. So that's the basic model that's available within SBM. So to enable segmentation of the spinal cord and neck or anything else, we wanted a framework that could actually learn tissue priors from collections of data, some of which might be labeled, some of which will be unlabeled. So the framework that we have for learning tissue probability maps is based on work originally done by Claudia Bliotta, which was part funded by the Spine Institute in Zurich. But there's been some ongoing work by my more recent PhD student, Mikael Bredfors. So this model is extended so that it can account for multiple subjects. And it learns a tissue probability map from the multiple subjects. And it makes use of the fact that there might be labels for some of the subjects in the data set. So that these see that encodes labels for some tissue types in some subjects. So when this model is run or is fitted, we can get tissue maps like so. So for these, it assumed two different tissue probability maps to encode grey matter. One tissue map to encode white matter, a tissue map that approximately encodes CSF, but there weren't any labels used, so just let the algorithm run. And then a bunch of tissue maps to encode stuff outside the brain. So this was trained using some labeled data from the 2012 MICI Multi-Atlas Label Challenge. So there were 35 Huon weighted scans. Some of them were of the same subject twice over, plus 20 T1 weighted scans from Belgrist that included a bit more spinal cord and which also included some manual labels, and a few scans from the ICSI data set. So some T1 weighted, T2 weighted, proton density weighted scans from ICSI. And when the model was fit, with some supervision about which voxels should be grey matter or white matter in some of the scans, it produced a set of tissue probability maps like this. And it also does registration. So we can assess the accuracy of the registration from fitting this model by doing cross-validation with the multi-atlas labeling challenge data. So this data set has regions of the brain manually traced, and the idea is to align subjects or align the MRI scans of the subjects together, and then bring the labels with them. So the labels don't inform the registration. And this allows us to assess the overlap of the labels of the different brain structures. Many people consider ants to be the kind of standard to beat when you're doing any kind of brain registration. So the registration was compared against ants. So here you can't really read this, but this is various different brain structures. The blue bars encode the overlaps for ants, and the green bars the overlaps for Claudia's work. And as you can see, the green tends to be to the right of the blue, which means that we get better overlaps than you do for ants. Ants usually requires brains to be skull stripped first in order to run things. But this was on non-skull strip data. If you skull strip brain images and then want to align the spinal cord, it's going to struggle because skull stripping usually chops off the spinal cord. So we can get good registration with this approach, in principle. We also extended the model slightly to make use of knowledge that we have about the intensities of different tissues. So in T1 weighted scans, the white matter is brighter than the grey matter. So there might be a particular mean and standard deviation for the intensity distribution of the different tissue types. We can learn these distributions from populations of subjects, and that makes things work a little bit more robustly, as long as you're just using T1 weighted scans, or T2 weighted scans, or scans with a known image contrast. So this is just taking the same basic model, but adding some priors onto the precisions or variances and the means. So we have these Gaussian Wishart priors that inform the model of the Gaussian distributions in the mixture of Gaussians. So this is just from a bunch of, I'll try to explain this. So proton density weighted scans on the x-axis, T1 weighted scan intensity distributions on the y-axis. And these ellipses show the Gaussian distributions for white matter and grey matter, and the blurry things in the background show the priors on the intensity distributions that have been learned. But the thing with this model is that it allows us to handle missing data. So if we're generating tissue probability maps with, say, the ICSI data set, we have good head coverage in the T1 weighted scans, but we have less coverage of the spinal cord in the other image contrasts. So we want to be able to use the other image contrasts to generate better tissue probability maps for brain. But we also want to make use of the data that we have available for including the spinal cord within the model. So if we have two images that we're trying to model the intensity distribution of for a particular tissue type, and if we have data in both images, then you think of those as data points as being black dots. If we just have one modality, then we essentially have information that might be analogous to these blue lines. or if we have data for the other modality, then it's like having the red lines. So we need an iterative scheme that can figure out a bit more about the kind of missing information. It can fill in the missing information. So it kind of iterates and then figures out the means and standard deviations of the kind of missing information. And that enables us to fit a model that can handle missing data. And we can assess how well missing data can be handled by actually using the same model for synthesizing missing data. So if we have bits of missing field of view, so these are artificially kind of chopped images. So just taking out bits of field of view that we don't want to include in the fitting, we can use, say, fully observed proton density weighted image and just partially observed T1 weighted and T2 weighted. And then we can try to infer the missing pixels. So we have no information from the T1 weighted image here or the T2 weighted image here, but we can fill in the missing values from this model. And we can use this to cross-validate our model of the data. And we can do it for, if we've got completely missing data as well, but this is less interest. And we can try for different image modalities. So anyway, that was the model that Claudia's work was based on, where she constructed a set of tissue priors. So again, the tissue priors she generated, I think she used 30 scans from the OASIS data set, some T1 weighted and proton density weighted scans of 23 adults from Balgrist and 600 adults from the ICSI data set. So OASIS had labels for brain, different brain structures, which were converted into labels for grey matter and white matter. The Balgrist data set had labels for where the spinal cord was. And the ICSI data set didn't have any manually defined labels. And the idea was just to run the training algorithm to generate automatically or semi-automatically tissue probability maps of different tissue types. So it was run. The tissue probability maps that Claudia came up with were these ones. So grey matter, white matter, CSF, and other stuff. Some of the tissue probability maps generated were then combined together. So the A class was fitted by several Gaussians, but these were combined. And some of the non-brain stuff was combined as well. The set of tissue priors that were released were only 1.5 millimeter resolution. But yeah, we can test out the tissue priors to see if they're useful. So this is an example of a T1 weighted scan segmented with the tissue priors. And it does, okay, that doesn't capture much of the spinal cord, but yeah, it's probably the wrong slides. But in principle, the method can segment some spinal cord, and it can spatially normalize as well. So this is the grey matter map for the tissue priors, and then this is the segmented grey matter map that's been aligned with those tissue priors. Because the data that went into these tissue priors are fairly low resolution compared to the size of, compared to the diameter of the spinal cord, there isn't really enough information to give a strong distinction between grey matter and white matter in the spinal cord, particularly with the 1.5 millimeter resolution of the images of the tissue priors. And this is an example of automatic segmentation of spinal cord. Using the same model, the tissue priors are available, although we're currently working on trying to get an improved data set and actually throw some CT scans in into the mix as well to get better maps of bone and vertebrae and things. To make things a bit more robust, we're looking to incorporate some additional work. Because when you're doing things with the brain, if you can get a good rigid or affine registration between the brain scans and some kind of template, then you can get fairly good results. But the neck bends. So you might get a good rigid registration of the head, but that doesn't mean that the neck is going to be so well aligned. So here's just a few examples. So if you take a look at the sagittal view, you know, you can see that you might be able to get a good approximately rigid alignment of the brain, but people hold their head in the scanner in slightly different ways. And if you're interested in comparing patients with controls, or patients with spinal cord injury with controls, the patients are likely to angle their heads in a systematically different way from the healthy controls, which isn't ideal. So we really need to try to make the alignment of the spinal cord more robust. So the idea of the shape prior idea is to encode the kinds of deformations that are needed for different sized heads or different angulations of head, or for people with kind of thicker necks or thinner necks. So there's quite a lot of variability in neck thickness, in how people kind of handle their head.
Rednecks.
Sorry?
Rednecks.
Yeah. So probably the South London people in the ICSI data set tend to have thicker necks, and the North Londoners maybe thinner necks. I'm not sure. But anyway, so Yale, one of my postdocs, did some work on kind of learning shape models from populations of subjects, and we hope to include that within the framework as well. So we get a kind of multivariate encoding of the way that heads and necks vary, which should allow us to align scans a bit more robustly. So the shape model is just basically having a new prior that we learn. So it's a prior on the shape variability. And I'll just skip through this very quickly. And this is just kind of modeling shape variability with different numbers of principal components. But I won't dwell on it too much. But anyway, there is ongoing work on the tissue probability map generation software. We're currently we currently have a multi-scale version that aligns images at different spatial resolutions in what I hope is a fairly optimal way. And the multi-scale alignment also gives speed improvements. Alignment is generally fairly quick because it doesn't do gradient descent. There's something called a Gauss-Newton optimization that tends to go for the solution a bit more quickly than just simple gradient descent. We've included a bit of OpenMP in the compiled C code that makes things run a bit faster. And we hope to package it up to make it a bit easier to be used in general. We can get a beautiful algorithm, but if the only person that can actually run it is the guy that wrote it, then that's not really ideal. So we'll do a bit of packaging. And want to include a more diverse range of image types in the tissue probability maps that we generate. So if we have a more diverse more diverse images, T1 weighted, T2 weighted, protein density weighted, CT, and possibly other imaging modalities, then the same framework should be applicable to a broader range of different types of modality. And then we're trying to integrate the shape variability model. If anyone wants to have a poke about what we've done so far on this, you can take a look on GitHub. The basic code's in there, and there are a few auxiliary functions that get used in this repository. These are the people that did the work. So Claudia started it. Mikhail and Yale kind of continued it. So Yale's in shape modeling stuff. Mikhail was a recent PhD student. And there was all kinds of funding sources scraped together to do the work. Anyway, thank you all very much.
Yeah, very nice. Do you mind going back to the priors that you showed?
The priors?
Probability match that you,
this set.
yeah. So, scored, where is it covered? I mean, does it not show up in the white matter, or is that just a matter of the size that you selected? Right?
Yeah, it should be there a bit, but it shows up more in the grey matter than in the white matter. If we combine the grey and white matter, then you can see it a bit more clearly.
Okay.
And if you render the combined grey and white,
I assume that's what that was, yeah. Yeah. And for the evaluation of the registration, did you also look at the, I suppose, the brain regions as concerned with the ants after skull stripping? That would seem like
no, but
that part, perhaps.
yeah, well, okay, but if it included the spinal cord, do you know any skull stripping algorithms that don't strip spinal cord off?
No, I see the problem, but you know, yeah, in the brain you're not doing a comparison against. You said this yourself, right? You're not doing comparison against normal use of ants.
Yeah, it's not the normal use of ants, but it is. You know, if people want to keep the spinal cord on, then
yeah,
then
it's
it's
interesting to know how
yeah. Well, the basic framework kind of works fairly well compared to ants anyway.
Yeah, it works well.
For registration. Well, there was the paper that Arno Klein did, where ants came out top for many of the data sets. You know, some of my stuff was coming out top for some of the data sets. And for the ones where it wasn't coming out of it, there were issues because the actual segmentation part wasn't working so well because, you know, most of my testing has not been on skull strip data. And the evaluation data sets were very tightly skull stripped. So, and my algorithms screwed up for the segmentation.
So you have a stronger case, you know, you can say as good as ants almost. In the brain, and you can do spinal cord.
Yeah. Yeah.
So actually to yourself, interact with
Do you register the subject similar to the template before?
I mean,
It's integrated into the algorithm, so there's a whole load of steps that it alternates between. So it alternates between doing the bias correction and the segmentation and the registration.
So this is a work process.
Yeah, it's a whole process. It's a generative model, so you plug in the original data. When it's not original data, sometimes you need to kind of reslice the original images to make it work. Because it expects, you know, the input images for each subject to be matched voxel for voxel. So you might need to reslice all your, you know, the other modalities to match the T1 weighted or whichever's got the bigger field of view. But apart from that, you know, if you just give it the original data, and it should do the registration and other stuff together.
Sorry, I was wondering if you could comment a bit more on how you learned the missing data. Could you repeat the question?
Oh, you want a few more comments about how the missing data is learned? Okay, so the data is, well, the input data is a bit like this. So you've got some points that you know, some points where you know the value of one image, and some points where you know the value of the other image, and this kind of extends to, you know, 3D, 4D, 5D, depending on how many input images there are. So it's it uses an EM type algorithm. So it's got an estimate of the mean and covariance, and then uses that to make an estimate of the means and variances of where you've got the missing data, and then those go in to the next iteration, and it re-estimates the mean and covariance, and then recomputes the kind of expected distributions of the unknown information, and just keeps iterating until it converges. And then there's a few subtleties to do with Gaussian washout priors and the intensities.
Thanks. Great work. I was wondering if there's a plan to include also atlases for doing atlas-based analysis in the spinal cord area.
What kind of atlases? You know, different people have got different ideas of what an atlas is.
By atlas, I mean, for example, the delineation of the different white matter tracts, corticospinal, dorsal roots, dorsal columns, and then like use those as regions of interest for example, computing metrics from DTI or MT-based.
So are you thinking more of a single atlases that will be overlaid?
Like for example, from the MNI space, there are like the Oxford Harvard Atlas that looks like different regions of the brain that are then used to generate ROIs for ROI-based analysis.
Not thinking about that too much, but if it is possible to get good nonlinear alignments, then in principle atlases could be kind of walked the same way. But I think it would be more interesting thing would be to include some kind of multi-atlas information. So if you've got a labeled map for an individual subject, then that can be overlaid onto your new subject. But if you've got many subjects where you've got labeled ground truth, then you can overlay the whole lot and then use some kind of patch-based machine learning approach to.
Right, but that would require to have the ground truth from individuals. So I was thinking more of like ex vivo based atlases that are known for like tracing studies, for example, and then that would be warped into like a template, for example.
Well, perhaps I should try to integrate stuff a bit more from the Human Brain Project in terms of the brain stuff, but the atlases don't really extend very far down the neck.
So yeah, that's a digital version of the Gray's Anatomy spinal cord atlas.
Yeah.
It's the spinal cord toolbox. So maybe we could discuss ways to integrate into your framework.
But yeah, I haven't really thought too much about integrating kind of structure labels within the framework. The original mission was just to be able to get a good spatial normalization segmentation of Patrick's MR scans. And you want to analyze it all within the SPM framework. So yeah, I haven't really thought about projecting atlases of new information on top of it.
Any questions? If not, then thanks a lot.
So the next speaker will be Joe Yokokan.
The microphone.
Great. Thanks very much. Thanks for the introduction and thanks for the invitation from Julian and Karen. For people who don't know me, I'm Yaro Kong. You can call me Joe if you like. I used to work in Oxford. Before a couple of years ago, I moved back to Beijing to set up my own lab, which is called Pain Neuroimaging and Translational Research Center. I'm working on spinal cord fMRI. Probably I'm the only person to talk about fMRI today, but I'm very happy to see like Rob, Falk, George, a lot of people who are working on spinal cord fMRI field. I know some people are very skeptical or critical about spinal cord fMRI, particularly someone from the very cold country. Yeah, you know who I'm talking about. So on behalf of our spinal cord fMRI community, I want to share with you some research findings in this field. Hopefully can convince you guys this is really reliable and very interesting field. Why are I myself interested in spinal cord fMRI? First, my primary interested research area is pain. This is a very severe problem across the whole globe. People spend millions or billions of pounds of dollars or euros on different kind of pain symptoms, but only less than 50% of people can receive good analgesic effects. So we want to study all these kind of different types of neuropathic pain or peripheral pain or different pain symptoms. And go back to a little bit anatomy. When we have noxious stimulus and from primary A delta or C fibers or from attached from A delta fibers, or we go through DRG to the dorsal horn of the spinal cord, then to brainstem and into brain cortexes. And then we have some cognitive processes and back and projection to brainstem and spinal cord dorsal horn. This is ascending and descending pathway of how we process pain, noxious information. Spinal cord is crucial. It's the main interface between the peripheral system into the brain cortex in the whole central nervous system. So when we have two types of things, when we have acute pain stimulus as health control, we reflect response to this kind of noxious stimulus, or when you have injuries to the peripheral system or to spinal cord or to the central nervous system, then become chronic pain. Either way, spinal cord is really interesting. So my lab focus on three things. We first need to understand the pain mechanism, either ascending transmit or descending modulation pathways, or how consciousness, memory, emotions affect your perception of the pain. And brain spinal cord imaging will be really nice to study it. Next, chronic pain, all different kind of chronic pain symptoms. From a lot of people now working on MS, on neurodegeneration disease, most of the patients suffer neuropathic pain. Again, brain and spinal cord imaging can help us to understand the mechanism behind it. And first assert the most important, how to treat them. If we have really nice anesthetic strategy, like now I'm working on electrical stimulation or some drugs or Chinese acupuncture, why do they work? Are they working at the spinal cord level or in the cortical level? With brain and spinal cord imaging, we can hopefully, we can answer this kind of questions. Go back a little bit, spinal cord anatomy. We have all the dermatomes of your body and map to different parts of the spinal cord. If we look into the axial plane of the spinal cord, is the gray matter of the spinal cord split into four horns, which is two ventral horn, control for your motor signal, and two dorsal horn, control for your sensory signal. This is very well-known anatomy, but this gives us very anatomical basis, biological basis, how to study spinal cord function. If we have a stimulus, for example, to the left hand side of your arm, it will only transfer to the left part of the dorsal horn of the body, and then contralateral to your sensory cortex. And for motor function as well, always this kind of laterality exists when you give kind of stimulus for resting state. And we can use this to study all these kind of biological patterns of the spinal cord, whether we can find out some biological meaningful networks fitting this kind of anatomy. Those are two major questions. One, use task. One, can we use resting state fMRI? Spinal cord fMRI, people can use different T1, T2, MTR diffusion. We all talk about a lot. We can find out atrophy, lesion mapping, demyelination, axonal loss, but only fMRI, we can find out some activation of connectivity or on the neuronal level basis. But spinal cord is very, everybody knows it's difficult to image, particularly for fMRI. All these kind of susceptibilities can cause artifacts or distortion dropouts for our images. That's why we have a figure. If we go back to 1996, all the way back, we have the first spinal cord fMRI paper until today, or 2018. The maximum year, probably 2008 or 15, have like 12 papers published this year. That's it. Around 100 papers the last 20 years working, we have spinal cord fMRI results, which is not a great number. And to prove you spinal cord fMRI is reliable, I'm very happy to see recent years we have some animal and human imaging work to prove this is reliable. For example, they have animal work giving nociceptive stimulation to the rats. When you have different level of intensity of stimulus, you can have mean arterial pressure goes up, and you can have spinal cord blood flow changes, and also you can have local field potentials signal changes in the spinal cord. But if you check the neurovascular coupling, the ratio between CPF and LFP is always stable. This is fundamentally important for us because we all know fMRI signal is from both signal, and the both signal is based on stable neurovascular coupling. So this shows that we can get stable neurovascular coupling in spinal cord. And earlier last year, there's one paper come out from Vanderbilt. They use a non-human primate model to study both task fMRI and residency fMRI, also electrophysiology as well. For example, when they give a tactile stimuli, the black line is a both signal. There is a delay on the HRF as what we see in the brain, but for the electrical signal, we see immediately up and off. So they have very nice pattern, exactly like what we expected in the human brain. In the resting state, if we look at the spinal cord into dorsal horn and the ventral horn, if we check three things. First is dorsal within slice, dorsal horn to dorsal horn connectivity, or within a slice, dorsal horn to the rest of the whole gray matter in the same slice, or the dorsal horn to the rest of the gray matter of the whole spinal cord. We have three types of connectivity. This is for the electrophysiology correlations. Always, yes, a strong connectivity from the same slice, dorsal horn to dorsal horn, and then the rest, dorsal horn to the same level of gray matter, or dorsal horn to the rest of the spinal cord. And also in fMRI, if we use the same technology to extract the both signal to do connectivity analysis, we found very similar pattern with. So actually, invasive electrophysiology or non-invasive fMRI data, we found some really similarity in there. And also from early last year, and this is the results, they use EMG to record your muscle movement. And they use three different types of movement, like wrist extension, wrist adduction, or finger movement. And they all cause different movement in the different parts of the muscle, and then cause reflections in your spinal cord. And if you use normal GRM analysis, with where start the stimulus, you can find some activation pattern, or they record the EMG from different muscle, from according to the different movement, use that as your design to correlate it with your spinal cord fMRI data, and they found out very nice activity pattern to different level, to a certain level of the spinal cord. So now I think this is a very nice study. We can link from the peripheral EMG signal to the spinal cord fMRI. So this is like three studies I like really much to show you the reliability. Can we use spinal cord fMRI as a tool to study the neural function of our central nervous system? Back to some other studies, all the years we have done in spinal cord fMRI, what we can do, use task-based spinal cord fMRI to publish good papers, yes. But most importantly, we can use this as a tool to answer some fundamental neuroscientific questions. For example, Fox study 10 years ago answer the placebo and the GCR question. If we give a stimulus to the left-hand side of the healthy control, we get some really nice activation of the dorsal horn to the left side of the spinal cord. And then you give some placebo, and then there's no activation anymore. So it shows direct evidence for the placebo analgesia. It happened in the spinal cord level. Although it's placebo, it's complicated like cognition process in your frontal lobe, but then give an inhibitory signal to the spinal cord, and we cannot see any spinal cord activation in the same place when we give a thermal stimuli. Or this kind of study, attention modulated spinal cord responses to pain. We all have experiences. If you're working really hard, if you think about something or distracted, you cannot notice the injury happened to your body or the stimulus you received. Why? Again, they use a similar paradigm, give us painful thermal stimuli to the left-hand side of your arm, and you can have some dorsal horn activity to the left-hand side of C6 dorsal horn, and then give them some working memory tasks, like one back, slightly, remember something one behind, or two back becomes really, really difficult. Remember two things behind, before, and now it's found out the activation from the spinal cord getting less and less, which means when your brain is busy working on something, actually you cannot suppress some input from the proper system already happening in your spinal cord level. And this is very interesting paper. I wouldn't go very detailed. They use a motor sequence learning protocol, but the most interesting part is they scan brain and spinal cord together. And when they showed the simple motor task or very complex motor task lets the subject to learn the pattern of this motor task, they found out both the brain and the spinal cord, they get similar pattern of activation. And also they use a model to find out both brain and spinal cord both contribute to this complex learning process. So again, answers some basic question for this kind of spinal cord plasticity of motor learning sequence. It happens both in the spinal cord and the brain cortex level. And back to Oxford, all the way back to like a few years ago when John Brook and I working together for some spinal cord fMRI protocol. Is very first we test if the laterality, like a sanity check, if we give left hand side stimulus, can we get the left hand side activation? Give the right, can we get both punctate and thermal stimuli? Get to the right level of the spinal cord? The answer is yes, but at that time we don't have like spinal cord toolbox or any other very good analysis tools. We can only realign all the slices back for some group analysis, which is not very ideal. So after, for years of study now, we have updated with our analysis pipeline, and now we can get some more decent results. So that's all based on the task. When we give stimulus to the subject, what can we see in the spinal cord? How about resting state? I said with dermatomes, with nice biological layout of the spinal cord, cycle cord, can we see some really nice resting state networks in the spinal cord like we see in the brain, like default mode network, sensory motor network, and this kind of network? The answer is yes. Falk and I scanned some resting state data, and we use ICA, and we managed to separate different biological meaning networks from the spinal cord into different dorsal networks and ventral networks. And all the networks, they are like within the same vertebral level of the spinal cord. For the dorsal networks, it can split into left and right because there's a laterality. You always to receive a left-hand side or right-hand side of stimulus. For the ventral one, is motor. You always try to balance yourself. And unfortunately, we cannot separate them for the left and right, partly because it's a 3T, or it's like we cannot separate them at all because they're always working together. And also, all these networks, they only correlated to the same vertebral level or next vertebral level. They cannot be correlated if there's a cross like 2 or 3 more distance of the segment level. And then This is by ICA networks, and sometimes it's not very straightforward to interpret how we can get these kind of results. And we all know in the brain, we can use seed-based functional connectivity analysis. The same thing is, yes, we can use in the spinal cord as well. A good friend, Rob Barry, started in 70 scanner, get some really nice 70 spinal cord fMRI data, and use a seed region, for example, from the ventral horn or from the dorsal horn. Although from this such small, tiny area of the spinal cord, it only correlated to the horns on the other side, wouldn't to white matter or CSF. So this definitely means something. The 70 kind of is not very straightforward for clinical purpose. So Falk and I reanalyze some of our data from 3T. And this time we use help from SET. With register anatomy with spinal cord toolbox, we can then get the atlas of the gray matter horns into our functional space. And then we can extract time courses from ventral horn and dorsal horns, and then we can check the functional connectivity between all these kind of spinal horns. Exactly, we find out only the dorsal horn to dorsal horn or the ventral horn to ventral horn, they are highly correlated together, not cross like ventral to dorsal or dorsal to ventral, same side or cross lateral side. And also this kind of connectivity pattern is consistent across different levels of the spinal cord. Does that reflect any biological, this is but fit with our understanding of anatomy, but does this fit into our clinical purpose? The answer is yes. Again, from Vanderbilt University, a couple of years ago, they scanned some primate in the 9.4, maybe ultra high magnetic field with monkeys. And for resting spinal cord fMRI with monkeys, and they found a similar functional connectivity patterns like we found out in humans. And then they did a spinal cord injury to the monkey. And then they found out the functional connectivity patterns in the resting state above the injury site still exist, but below the injury site, all the connectivity patterns are gone. So it implies probably this can be a marker for potential spinal cord injuries. And again, from Vanderbilt, Seth Smith's group, we first tried it on the MS patients. They managed to publish 2 years ago in Brain, but unfortunately, I'm not sure due to the low temporal SNR or less of patient numbers, they found always some like patterns, like differences, always decrease dorsal horn to dorsal horn connectivity or ventral horn to ventral horn connectivity for the patient compared to controls, but it's not very significant. Also, they studied whether this connectivity affected by the location of the lesions. Yes, they do find a trend, but not, again, not very significant. So for us, we want to imply this technique into clinical applications, and we want to find whether we can have some solid proof this resting state spinal cord fMRI can use for clinical trials. And I'll give you a couple of examples we have done last year. First one is collaborated from Hong Kong University. We scanned some patients with CSM, with myelopathy. Basically, there's press in the disc to the spinal cord. They suffer some numbness and cause some problems in the neck and mobile disability as well. And we have structural data as long as resting state fMRI data. And with the JOA, which is a clinical score of the CSM, and we can quantify CSA or APCR, which is a compression ratio of the spinal cord, how the shape changes of the spinal cord. And from resting state fMRI, we can quantify, again, ventral horn to ventral horn or dorsal horn to dorsal horn functional connectivity. And what we found out is from dorsal horn to dorsal horn, there is no significant difference between healthy controls and the myelopathy patient. But for the ventral horn to ventral horn, the patient connectivity significantly decreased. It is quite significant. And more importantly, for the ventral horn to ventral horn connectivity nicely correlated to their clinical score, which means if they have small severe myelopathy and they have a less ventral horn to ventral horn connectivity, it's very nice correlation.
Is this at the level of the compression?
No, it's overall. It's overall average for the whole cervical cord. And yeah, I'm not sure. We haven't checked for like slice-wise or location of it. And we only do a like regression here. Like here, ventral horn to ventral horn connectivity after controlled with the site of the compression, age, duration, everything. And still, ventral horn to ventral horn connectivity come up with the most significant difference and correlated to the clinical score. And this one is very nice. When we have the compression rate along the cervical cord at each cervical level, and we have ventral horn and dorsal horn connectivity, and if we do a regression model, this ventral horn to ventral horn connectivity correlating nicely to the compression rate. So this reflects with where it happened with the injury, not the dorsal horn. It's always ventral horn to ventral horn. So for myelopathy, this is what we found out. I think it's very interesting. And again, we move down to lumbar disc. We have cervical myelopathy. Now we have lumbar disc protrusion or herniation. When they have lumbar disc protrusion, and quite often they suffer chronic pain. This is a major reason why they have chronic pain. And we scan again the structural and resting state fMRI. My PhD student Ji Yuan has done it in Beijing. This is some results. Although we scan the cervical cord, which is not the disease or lesional damage area, the really damaged area in the lumbar disc, but we scan the cervical cord, which is on the pathway for all this information go into your brain cortex area. For the structural analysis, we use spinal cord toolbox. We can segment the whole spinal cord, or we have medic scan. We can segment this gray matter, and subtraction we can get white matter volumes. And we got interesting results for the patients. It's like 35 patients altogether, so it's quite a reasonable number of patients. And we have significantly decreased cervical volumes of from the patient compared to healthy controls, not for the gray matter or the white matter. So the effect is global. So if you have lumbar disc problems in the cervical cord, it shrinks the cord overall, not particularly in the white matter or in the gray matter. And very interestingly, we have McGill pain score, which is what's the degree of their neuropathic pain, nicely correlated to the whole cord CSA, which means if you suffer more pain, if your degree of your neuropathic pain is more severe, and you have much less spinal cord in the cervical area. There's very direct evidence this already effect in the cervical area. Look into the resting state connectivity. We co-register the resting state fMRI into the T1 structural scans, and then to the spinal cord toolbox PAM50 template. And then we can get the atlas back to our fMRI space, and then we can extract time courses to different ventral horn, dorsal horns, and then we can do connectivity analysis. And very interestingly, this is ventral horn to ventral horn connectivity, slightly higher for the patient, but not significant. Most significant difference from the dorsal horn to dorsal horn. We guess because they suffer constant painful stimulus from the lumbar disc all the way to cervical cord into the brain cortex, then probably like cervical cord is like central sensitized, and then for the dorsal horn to dorsal horn connectivity becomes significantly higher for the patient. And we didn't find this connectivity highly correlated to their pain score. There's a trend, but not significant. But the other findings are really interesting. And we have another measure called pain sensitivity, which is how vulnerable the subject when they receive any mechanical or a thermal different type of pain. And for the healthy controls, the dorsal horn connectivity actually positively correlated to the sensitivity, which means if we measure the dorsal horn to dorsal horn connectivity can predict how sensitive when you receive a pain stimulus. Actually, if this kind of people are more sensitive to the pain stimulus or more vulnerable, maybe in the future, when they have this kind of disease, they are more likely to develop into chronic pain. But on the right-hand side, this is a patient already have chronic pain. Actually, the dorsal horn connectivity becomes negatively correlated to their sensitivity, which means there is now the inhibitory mechanism start to kick on within developing the chronic pain. And this is agree with some animal study when they have rest of the chronic pain, neuropathic pain model. And I'm not sure for which kind of channel, can't remember, but and there's some inhibitory neurons activity in the spinal cord. I only can speculate, probably that's the reason. But this is, for me, this is a very interesting finding, which means for the healthy control, is a positive correlation with the sensitivity, but for the patient, it becomes negative. So there's like yin and yang side of this. Maybe give us another kind of phase where this resting state spinal cord fMRI can be useful for clinical trials. And now we're doing some other studies. These are still ongoing, not finished. I only gave some preliminary results for everyone and to look at it. This is spinal cord hyperextension injuries, real injuries, very serious. When they happen through this, with a car accident or some other accident, they have this cervical cord hyperextension injuries, and it's very acute, happen really fast, and progress within 72 hours into very serious injuries. And they're gonna have surgery and recover like in a couple of weeks. And what we propose to do is we scan them when they have very acute stage of the spinal cord injury. And then with all the clinical check, also with our, because we're still interested in pain, with the sensory, motor, with all these kind of neurological examinations and pain questionnaires and also emotion questionnaire as well, and also spinal cord and brain MRI together. And after surgery, we scan them again and the follow up three months time, we check again. So basically we want to find out brain or spinal cord imaging, structural diffusion, and resting state fMRI, which one can actually to track the progress of the disease, of the treatment of this disease. And we so far, because it's really a hard disease to recruit, so far we scanned around 20 patients for the baseline, and only we have like 10 or 12 subjects with before and after surgery. I can only show you some preliminary results. Sorry. For example, the pain scores significantly decrease after surgery, which means the symptoms already, they received the good surgery and recovered well. And if we segment the spinal cord, get the cervical CSA or the compression rate compared to the measurements before and after surgery, we also get like higher CSA, also higher APCR, which is not significant because when you only have like 10 or 12 patients, this is still ongoing. Once we get like more subject numbers, hopefully this can boost up, which means the structural index can track how well they perform the surgery on the spinal cord. The other interesting finding is on the DTI, like intact area of the cervical cord or injured site of the cervical cord. If we get FA value out of it, and particularly we use SED again to do the correlation, we can extract FA values from corticospinal tract or spinal thalamic tract. We always find that in the injury site, FA values in the both tracts decrease, but very significant in the spinal thalamic tract. So which means we have problems with their sensory function and motor function. And we're gonna keep monitor this after surgery, whether this is gonna be recovered, and also resting state fMRI as well. And Romina is from Oxford, who's here, and we are doing another clinical trial. And we know neurodegeneration disease or demyelination disease, MS and MO, and the new disease called MOD. It's very difficult sometimes to differentiate them. So what we try to do is we scan the spinal cord with structural DTI, MTR, MPM, a new sequence from Daniel. You can talk to him if you're interested, and resting CFMI as well. We collect the clinical scores like disability, pain, fatigue, and with 1-year follow-up as well. We want to find out whether this spinal cord MRI can actually first differentiate 3 types of neurodegeneration disease, and the second, whether they can, during the follow-up, can track the disease progression. And we get some preliminary results. You can talk to Ramina for details if you like. And for like whole CSA, cervical cord CSA, always NMO is most significantly decreased. But if we segment the gray matter of the spinal cord, always MS is most significantly decreased, which means MS is more like gray matter damage disease, and NMO or MOG is like whole cord atrophy. And also the CSA correlated nicely for both patient group with their EDSS score and not for the MOG. And this is very interesting results. If we use SCT to co-register the DTI data with the palm, and we can get in the standard template the atlas of the tracts, and we can segment the spinal cord white matter. We can get the spinal thalamic tract and corticospinal tract FA values from the data. And interestingly, from corticospinal tract, FA value correlated nicely with the EDSS with disability, which is reflect the motor function. But for the spinal thalamic tract, it correlated nicely with their pain score, with brief pain inventory. So nicely in the white matter with different tracts, we can separate their motor and sensory pathways, and both reflect nicely with clinical features. So back to basics. I've talked a lot today with some literature review and some ongoing projects and with what we want to do. But back to the basics. Hope you'll find out first, it's very difficult to do spinal cord fMRI. And second, it's I think this is reliable and also promising tool to study the function of the spinal cord. But there are some other questions we need to address, like what kind of acquisition method we should use, like where in the spinal cord, how large was the TR, TE, saturation band, and zoom it, non-zoom it, cardiac gating, anything. Which one is optimized parameters? Analysis, what kind of filter, high-pass filter, smoothing, and denoising. We always know spinal cord affect a lot from physiological noise, cardiac, respiratory, and what's the best denoising method? And also, what's the best correlation method? Currently, we can only use the spinal cord toolbox to map the palm 50 back to the fMRI space. For the other way around, if we want to integrate it together with, for example, FSR SPM, we want to analyze activation patterns in the standard space. We talked about for the last couple of months, we still need to get that problem solved. The other thing is, I only show one time spinal cord fMRI scans. How about reliability and reproducibility? Like everyone checked for the structural DTI scans. fMRI, we still need to check for the reliability. We can get fMRI activation or connectivity or networks, functional networks. Are they still reliable and reproducible? And whether these spinal cord networks or connectivity really reflect the biological mechanisms, like mapping to the different dermatomes, to the sensory threshold, pain threshold, to the symptoms, and everything. And also, then we can answer the question whether this can be possible markers for the disease of neuropathic pain. So in Beijing, probably lots of you know this guy, Yao Liu, and we know a couple of years ago in the MS meeting, and he's really interested in spinal cord. So we want to do more of this kind of spinal cord fMRI work together. Like Julian already proposed a project, we can have a generic protocols for structural DTI, MTR. And now we want to see whether we can have a generic protocols for fMRI. And all the images we scanned in Siemens scanner, for example, the standard EPI without any tricks, any good special sequence, on the SkyRA, we can have very good images already. And with trio of very old scanners, we can use Z-shim sequence and give different shimming parameters, slice Z, slice Y's. We can improve the API quality, or with the newest zoom it, limited field of view in SkyRA or Prisma, we can get very nice images as well. Or we attempt, can we image brain and spinal cord together to understand the whole central nervous system function as one goal. So we want to, this is first step, we want to check. First, we can get good image quality in Siemens scanner. Next, can we get in GE or Philips cross-platform? And also, can we get really nice, reliable, and reproducible data from different sites or scanners as well? So I'm very happy, for people to, work together for this kind of project. If you're interested, let me know. We can just scan some patients or healthy people together and see whether we can reproduce all the fMRI, resting state fMRI results. That will be really, really interesting. Already this one, we scanned more than 50 subjects, we scan, rescan, and this we tried to optimize analysis protocol. We're still is working in progress. For the denoising models, John Brooks and I proposed the physiological noise models and already integrated with FSO. We always know when we scan fMRI, every TR, this is, you can see the CSF going up and down, and when you breathe in, breathe out, with the change of location and susceptibility of the MR field, and the cardiac as well. If you measure the cardiac and respiratory, that's a must, which we do spinal cord fMRI, and you can regress out the physiological noise out. But if you don't have these physical settings, some people propose they can use ICA or PCA, some other post hoc analysis to clean up your data. And we did a simple check. If you use ICA to denoise it, or if you use our PNM to denoise it, or if you combine them both together, you can always boot up your TSNR in spinal cord data. But actually, the resting state functional connectivity always decreases. Because when you clean up the noise, maybe due to the same cardiac cycle, respiratory cycle, or CSF pumping, actually the connectivity decreases. So be careful if you want to publish any kind of these results. You need to check whether you have really good physiological noise denoising method. But which one is optimal? We don't know yet. And we scanned like 50 healthy subjects. We're going to calculate this using different analyze protocol, different denoising method, and we're going to test rescan, rescan reproducibility, and we have all the behavioral measures, and they're like sensory or pain threshold, and we're going to answer, hopefully we're going to answer which one can give you the optimal denoising or analysis pipeline. And yeah, still working in progress. Hopefully we can understand that. So now we proposed, probably this is a method we use so far together with spinal cord toolbox. We have to do some correction, B0 with slice-wise motion corrections and spatial smoothing. We have to use physiological noise denoising, high-pass filtering, and then for the registration, we use together with the spinal cord toolbox, and then we can go back to the spinal cord, sorry, to the fMRI space to compute connectivity, or we can do the task to do group statistics. So this one is still under development. I still want to find out what is the best way to do it. But for the resting state, we're pretty happy with the protocol we're doing right now. Okay, in summary, quantitative fMRI spinal cord, quantitative spinal cord MRI, like structural diffusion MTR, like you always do, offers insight into structural white matter integrity, lesion mapping, tissue composition, all these kind of things, and this is really good. But spinal cord fMRI can offer insight into neural activity. That's what interested to answer the motor dysfunction or the pain symptoms from the patient as well. And we aim to develop robust spinal cord fMRI protocols analysis pipelines and open to more neuroscience and clinical applications. And by the way, and last August, we already have a spinal cord toolbox course in Beijing. And with very short notice, we attracted around 50 people. So now a lot of Chinese researchers are really interested in spinal cord. And last October, we have an FSO training course as well in Beijing. So if you want have like spinal cord, maybe next time MRI workshop or this time training course, or if you want collaborations, you can always talk to us, and we are more open for collaborations and advice, suggestions, etc. Finally, I want to thank my team in Beijing and my students and Oxford's colleagues like Irene, Jackie, Romina, Andy, and also all the people who used to work in Oxford together. Now we separate apart across Europe, but still work closely together, like Falk, John Brooks, George, and Johanna. Everyone contribute to spinal cord fMRI development. So thanks very much.
Thank you very much, results. I was wondering, what are your usual acquisition times for such results?
Acquisition times?
Yeah.
Oh, we aim, for example, if you only scan spinal cord or cervical cord, normally like 20 slices or 25 slices, we limited the TR around 2 seconds. And then we scan for like 10 minutes. So at least 200 volume. And then we can get some kind of reliable connectivity. Yeah. There's no like gold standard, but there's somehow we found it's quite feasible, at least, to do. Alan?
How consequential are the differences in hemodynamic costs on brain and spinal cord? Did you have to do anything with your pipeline to optimize that?
Sorry. Oh yeah, sorry. Yeah, Alan asked different HR functions like in the brain and spinal cord, how we cope that differences, or can we, what can we do for it? Yeah, the answer is no. We wanted to try to explore that answer a few years ago with John Brooks and Falk, but we didn't do that. But actually, probably we should do that. And I noticed one paper a few years ago, they investigated it with different lengths of stimulus, and they found out like HRF in the spinal cord actually longer than the brain. But we didn't do that, and we still use very mechanical HRF and model in the GLM, and we found out some reasonable results. And also when we found some activations, I go back to that extract the volt signal and do some linear deconvolution. I didn't find any like longer HRF myself. So since then, I always just use the default, same as the brain. But you're right, probably I should pay more attention to that, and according to the different parts of the spinal cord, whether there is variation of HRF, or we should use a set or the basis function of the HRF in the future to model better spinal cord activation.
I wondered about the missing intercorrelation about maybe the segments of the resting stage networks because I expected based on neurophysiology, or sort of a sequential representation.
Yeah. Yeah. But if I understand right, you asked about like different intersegmental differences of the functional connectivity. And I use ICA to explore the functional networks, and I do find out the nice pattern for that. But ICA sometimes is very arbitrary and difficult to interpolate. And later on, we switch to seed-based connectivity. And now, all the results we get so far is we average the cervical cord connectivity together instead of see the different levels. And because you can see the connectivity correlation is like 0.2, 0.3, which is not great with all the noise and the lower TSNR in the spinal cord. And we found out if we look into different segmental levels, and the results are not that significant. And so far, it's like F3T, we cannot really segment into different levels and explore the connectivity, how that link to different dimensions of things. Only for the task fMRI, when we do the activations, if you give different area of your body, and that fit into different dermatomes, and then we can see the different activation regions. But for the resting state connectivity yet, I mean, personally, I haven't done anything, look into different segmental levels. I will, but not now. We collect huge amount of data. It's still working in progress. Try to answer that. I'm not sure, or if you talk to Rob Barry or Falk, have they got different answers to that?
I was wondering if you have tried to lumbar spinal cord.
Lumbar spinal cord. The answer is no. It's too difficult. With a hardware limitation, now we only scan to the cervical level with a good coil, and then we can get good spinal cord fMRI data. I tried to the thoracic, and we can get good structural, but for the DTI, diffusion, and fMRI data, no, I don't think that's so far is not feasible. So in the future, if we have better hardware developments or better sequences, I don't know, probably we can, but for the lumbar, I don't even dare to think about it. Sorry.
Okay, let them just speak again.
Thanks very much.
So we're going to just the final speaker of the session today. And so I introduce John Suttis, who works with us here at the MS Centre Trials Unit. And the title of his presentation is Data Management Lessons for Spinal Cord Study.
So PPT.
What are you looking for? The closest one is there. But you can use this one. Let's get it. My one is already charged. Well, one is in from the next.
Notes. That's the main screen.
What do you need?
Get the notes up on the front of you.
Ah, you want the presenter view?
Yeah. If that's not going to show on the main screen.
Slide. I don't know if it's going to work.
If it doesn't also show what I was going to say.
Ah, yes, it's working.
Good.
Here?
Yeah, so, cool. Yeah, hi. So I'd like to talk a little bit about data management at Forensic Quest. I gather this is quite useful for people. It's possibly not the most interesting thing you'll hear today if you're here to hear about spines, but there we are. I'll try and keep it short because I know you've all got bowling to attend. I did try when I was writing this to focus on things that came up during a spinal cord trial, but really this is mostly general common sense things. If you're doing brain work or kidneys, it's going to be the same real issues that come up. A little bit of background. I'm the data manager at Queen's Square MS Centre, and I've been there for about 6 years. Mostly we work on MS studies. A number of those have had spinal imaging components now, primarily the cord area, which we've now heard a lot about, and also a little bit of lesion detection, but not a great deal. I'm also the data manager on the Inspired study with Becky, Claudia, Julianne, et al. And that's looking at CSM and SCI, but it's quite a small study, so we haven't had too many challenges there. So what is data management? For me, it's the smooth flow of information from your sources, so your scanning sites, into the organization in which I run, so the trials office, I say run, that I'm responsible for the data management of, through the storage of that data, processing it, and then its egress to clinical trial, to the clinical sponsor, or to academics if it's an academic-led study. So we're generally running clinical trials where we are, but this is very applicable if you're just an individual researcher as well. You have egress yourself, you have data coming in, you have your own processing and storage to consider, and then you have your own egress. Even possibly egress might be to yourself, but you're analyzing that data, or
putting it into a repository, but it's the same way of thinking about data you can apply elsewhere than in a clinical trial setting. So lesson one is standardize as much as possible. I've found that really the most difficult part is getting the ingress right. It's, I think, because you have the least control at that point. You're working with multiple sites, maybe. Number of radiographers might be involved. There's limited communication. You don't have much control over what comes in. Once you've got tidy data, everything's moved quite nicely, but getting data in the first place and getting it tidied up is quite challenging. So, as I say, the ingress, as I see it, there's a number of scanners or maybe packs being exported. This is across all your sites potentially. So you might have 20 or 30 different scanners or different pack systems, 20 or 30 radiographers, probably more radiographers. You've got a lot of people providing data. They're all going to give you a stream of DICOM images. That's going to come into our site through one portal and then get passed on for QC and processing. So you try at this point, I think, to cut down the variation as much as possible. So you want clear scanner protocols and site qualification to make sure everyone's doing what they should be at the beginning of the study. Obviously it helps. It's very good today that we've heard a lot about standardization of both structural protocols and functional protocols potentially going forward. If everyone's on the same page about how you scan structural spinal cords, then you're going to have a lot less trouble with this than you are if everyone is trying to do a different thing. People have already got their own protocol in one center, a different protocol somewhere else, and trying to get everyone to work together is much harder. So I say it's good that the work is being done to get the community as a whole to agree on how people scan these things. On a more practical level, when I arrived, we were using SFTP, which is it's a good protocol. It's very secure, it's very robust, but it gives the sites an awful lot of leeway about how data is uploaded. That results in this mess. This is one site's upload. You can see that trying to work out what came from where in this, who was scanned when, is not easy. You can imagine 30 sites all doing this. Exactly. It gets very difficult to know what's come from where, and you need to really have a good sense of what I'm looking for. A good sense of where your results came from and how that fits with their source images, and that's very difficult if your data looks like this. One of the first projects I worked on, is that going to work? There we go. One of the first projects I worked on when I arrived was switching from SFTP to a web system. So we now have a form that you fill in. There's much less leeway on this for individuals' opinions about how is a good way to upload data is. The subject number is fixed, so you're going to have a certain number of digits. The time points are all our names, and then that gives us a much cleaner folder structure at the end, which makes me very happy. Obviously, there's a limit to how far you can go with that. The scanner manufacturers have different ideas about how they want their DICOMs to be. You can't do very much about that, unfortunately, but yeah, we live in the real world. There has to be work somewhere. So lesson 2 is to try to help streamline QC. You want to QC thoroughly, but you also want it to be quick because it's not a particularly interesting part of the process. Visual assessment of image quality remains the best way to do QC, really. You've got to actually look at the images as they come in. If you've got the opportunity for rescans, quickly reviewing them visually is the most important thing you can do. You need to check they're compliant with the imaging protocol you've designed. You know, you do your site qualification and it all seems great at that point, and then 2 years later, protocols change, scanner versions get updated. You've got to keep an eye on this because people will pull the rug out from underneath you. Obviously, in clinical trials, anyway, in fact, for all of us, data protection is a big thing. You need to make sure that there's no personal information that's crept into any DICOM headers anywhere. Again, the manufacturers don't make this easy because they'll hide things in private fields, and you need to think about how you're going to do this. One thing that we found very useful is to do a preliminary analysis, or in fact, indeed, the actual analysis where you can. As Mark was saying earlier, the gym cord area is very quick. You can turn that around as part of the QC, and then you know, because you've already done the analysis during the QC, that you've got a core that is good enough to analyze because you've done it. So if you can turn around a result in 5 minutes, then why not do it in your QC if you've got someone who's qualified to do it? I, as a data manager, can help by try to automate things as much as possible in scripting and creating tooling to make these checks as easy as possible. This DICOM check is a tool I'm trying to get together for comparison of DICOM headers, both looking from original DICOMs, trying to delve into nifty metadata as well, and also potentially comparing bids, JSON sidecars as well, to try and get one package that can compare either to a reference file or to a previous scan. Again, I would welcome some help with that because it's a good idea. It's not an idea I have a great deal of time necessarily to work on. Again, as I was saying, if you can do some preliminary analysis, that's a very good idea. These are some plots we use for diffusion, so we just very quickly check for motion using the plot on the left and produce an FA map during the QC. And then again, as I was saying, similar thing with the chord area, you can look at that and say, yes, we've got clear CSM, we've got clear corpus callosum, that is orientated correctly. Then you're fairly sure that once you've used the full pipeline, you've done all your motion correction and everything else, you're going to actually get a decent diffusion result. That's not necessarily apparent from just a visual inspection of the raw data. Lesson 3. So we hear a lot, obviously everyone's very excited about advanced protocols. The problem with advanced protocols for me is that they take up a lot of space. So 2D Flare a few years ago didn't take up any space, sort of 10, 20 megabytes. We're now, this is looking at Inspired, which is not a big study. It's taking up 340 gigabytes in a minute. You can imagine as soon as you back that up, you're over a terabyte. That backup shouldn't be in the same place. So how are you going to move it around? You're moving terabytes of data backwards and forwards. And again, sort of, you need to do something more than mirroring it, because that doesn't result. You need some protection against accidental deletion as well as hardware failures. You've also got to think about how you're going to archive that. Again, you're not going to put this on CDs or DVDs anymore. It needs to go on to potentially tape. Not a lot of people, I suspect, in the room familiar with tape backup. It is still a thing, believe it or not. And also how you're going to dispose of that data, because you've got all these backups, you don't need to get rid of them. I'm happy to talk, if anyone has got any specific questions about how you might want to do this, I can talk about that. Specific examples are a bit tricky because it will vary depending on what you've got available in terms of infrastructure. As I say, even if you're an individual researcher, this is a problem. This is only 40 patients, and if you want to look after it, you're well beyond what you can carry around in your laptop bag with you anymore. Lesson 4. So I don't know how familiar people are with containerization. Maybe Docker or Singularity, you've perhaps heard someone mention. They're a little bit like virtual machines, which again, some of you might have come across. The virtual machine, maybe in the form of NeuroDebian, if you've heard of that, is a whole computer essentially in a bit of software. Container is an idea to sort of strip that down. They're much lighter weight, so virtual machines are maybe 2 or 3 gigabytes. They're quite big things to download and move around. The containers are much smaller. They're more like 20 gig. 20 megabytes potentially for a very small one. What that gives you is a self-contained unit that contains maybe part of your analysis tooling. So you might have SPM in a Docker container or SCT in a Docker container. And then that is decoupled from the system you're running it on. So you've got your own laptop or your own PC that is, you might have the version of SCT you use to look at data with, or your version of SPM that you use to muck around with. You have separate to that a self-contained environment in which you're doing your formal analysis. So you're not playing around anymore. You're actually going to produce some numbers that you're going to publish or send on to someone else. You've then got this container that is not tied to your PC anymore. So you can play around changing your versions. Then if you need to come back 2 years down the line and reanalyze, you've still got a container that hasn't changed. It's really, really useful. The downside, as I said, is there's a bit of setup involved. It's not programming exactly. You don't need to sort of panic. You just have to take the commands you put into a terminal, which you maybe find in the manual for the software you're downloaded, put that into a file, and then run that, and it will create a container that is running the software. Again, this is a bit intimidating. This is an entire analysis, but you can see that it's not actually too, if you break it down, you're copying in installers, and most of this is just adding installers, and then there's a bit of running the installers down here. The end result of this is the entire environment that I use to analyze the inspired study data is in one place. And then I can move that to a different PC. I can come back to it in 2 years' time. This is something that you can use now. It's not too bad to write a small one of these. If some tools are starting to provide their own container now, so you might be able to not, you might go without writing one of these. You can possibly download it. I really, yeah, it's made my life a lot easier, and I like to think it potentially makes some of your lives a lot easier as well. So going to a quick example there. Singularity is a variation on Docker. It's turning out for me to have some practical advantages because you don't need to be an admin to run it. It means if you've got access to a computing cluster, some of you might be lucky enough to have a kindly computing department. They will not let you run Docker because that means you have to be an admin to run the Docker container. They will let you run Singularity if you're lucky. So it's worth considering. If they say no containers, you can come back and say, oh, no, not so much. We can use Singularity. I don't need to be root to do that. Okay, last lesson is data transfer specs. So the way that we communicate from our trials office to the sponsor, how we will send them data, is a formal document describing that called data transfer specification. It's very closely tied to your study endpoint, so your clinicians or whoever your investigators are will learn what they need to know about first. They've made that decision. This is formalizing that in a way that a programmer can actually use it to maybe validate a document that you're sending them, or to create a document in the first place. Find it very useful for focusing the mind on what you're actually going to produce from your study. So again, it could be, maybe you're not transferring data anywhere else. It might be you might find this is a useful way for you to focus your mind on what your analysis is going to produce at the end. So this is the table of contents from one DCS that we've got. So you can see from here who is responsible for it, how has it changed. Again, you've got, if you're particularly working in clinical trials, you in ideal world you would never rewrite this, but things happen. People get ideas 6 months or the end about something they'd like to know, so you keep track of that. Some boilerplates, inevitably, and then we're describing exactly what the file will look like, some nuts and bolts of it. And this is, it's technical information, but it very clearly defines what you're going to do in a way that is potentially quite useful. And then down here some information about how we're going to send that data out and who we're going to tell, which is more specific to working with sponsors. This is a little bit more detail about what you might have in that DTS. And this is something that comes up with open data as well. We're obviously very keen to start sharing data. If you want other people to be able to use your data, you need to have a clear way of defining how that data is going to be provided. This is something you might want to consider in that form. So you can see we've got very clearly what is going to be sent, what format it will be in, if there are a limited range of options, what those options will be. Again, it's all simple stuff, but if you don't make a decision, then people won't know, you work with an American company or an American academic and they change this around and you've got no idea when people were born anymore because you didn't bother to write down what you'd done. Again, there's a little bit more here, getting into sort of particularly detail about exactly what you're measuring and what units it's going to be. You'll notice that there isn't, this document won't say how you're coming to that. So you wouldn't talk about software versions necessarily in this. It's not the way we do it. You'll need another document describing the analysis plan, so what software versions you're going to use, how they're going to connect up. But the way we approach this, that's out of the scope for a DTS. Right, so hopefully that was brief. If you've got any questions that don't relate to bowling, because I'm hopeless at bowling, I will attempt to answer them. John.
Can I ask something that's of interest to our department? You didn't say anything about data sharing, which is a requirement for some funding bodies, but is apparently against the law according to Data Protection Act.
So, well, I'll fill in the gaps with your question. John's question is, how do you deal with data sharing, which is a requirement but also against the law? The answer is, I don't make that. I don't have to decide that. Luckily, it's the sponsor's job. I do not have a good answer. I think that the brain structural image is potentially a biomarker on its own and thus protected data under some interpretations, and you're into a real pickle as soon as you go anywhere. I think the spine, luckily for everyone here, is easier because I think you can make a pretty strong argument that the spine's not a biomarker, not as an identifier. It's down to the test is about motivated attempts to de-identify the data, and how far a motivated person would go is not a question I think anyone's really got a good answer to yet, unfortunately. So, yeah, helpfully, I don't know. If the film make a decision, I'd be interested to know how they decide to do it.
We'd be interested in if anyone else made a decision.
Yeah, a question for the group: how are we going to do this? Possibly.
John, any special because you depicted a couple of generic issues around data collection? Anything specific related to spinal cord imaging where you have to put in another layer of scrutiny? Because they tend to be more challenging, more rejections.
I think.
On the input side.
For the spinal cord,
yeah.
when the people does the dedicated scan of the spine,
yeah,
that you see the cerebellum.
Yeah.
Because if you don't see the cerebellum, then you don't know if you are on the top or not. Spine you cannot call the
Yeah. So the question is specifically issues on the QC side with spinal cord, I think.
Yeah.
As you say, there are more data quality issues, there's a lot more motion in the cord. We all know here that the cord is hard to image, harder than the brain to image. As I was saying, the best thing we've found to do is to analyze the cord when it comes in. If you can do the GIM analysis or your SCT analysis in the time that your QC person has available, then do it. Maybe you do an improved analysis later, but try and do something to assert that your software can handle the data you've received.
So I would have a follow-up question to that, which is, let's say you do the analysis and then you find cross-sectional area of X. How do you decide that this is a reject or an accept?
So the question is, how do you accept or reject? Mainly experience. You have QC people that know what they're doing. If you're lucky, the literature is decent. In the case of cross-sectional area, there's now a fair amount of data. We can say fairly confidently across a number of tools what sort of cross-sectional area you can expect. Obviously, if you're dealing with injury, then that does become a bit more difficult. In MS, you wouldn't necessarily really expect to see really wild numbers compared to healthy controls. And there's a fair amount of literature about what you can expect to see from there. So you've got guidelines and literature and experience. Anything else?
I have a question. So you did mention, or maybe you did the BEAT, the Brain Initiative data structure. What's your take on that? I guess it's more for the last part of your talk and how you basically deliver your data for possible sharing.
So question about BID. which is the brain imaging data structure. It's a cross-group effort to formalize or provide standards about how we store DICOM, so file layouts, really nitty-gritty stuff, and accompanying files, so you can tell what the metadata of that file is. Nifty files don't come with much metadata, so the BID specifies a JSON sidecar, an additional file that has TI/TR, various other things. For functional imaging, it's also got a lot of extra information there. My take, last time I looked at it, it was a bit light on detail for structural imaging. It seems, I think the functional community are using it a lot, it seems, and there's a lot of tooling around it for functional imaging. I immediately ran into things that weren't in the spec and didn't have time to do enhancement requests to the spec at that point. If more people start using it and they find the holes and have time to fix the holes, then I would quite happily start.
So I can say that the community is extremely active. The community also from the structural side. There's a lot of proposals.
No, I've turned my notifications off the because it was a bit aggressive. But,
so they are working on all the different issues, how to treat the derivatives of QMR, maps, and things like that. So I think it's moving forward very actively.
It's an impressive project. I think it needs involvement from physicists, if there's any physicists in the room, because they are the people that know what you need to know about data to process it. I have opinions about how data should be laid out, but that's not really, BIDS has largely solved that problem in a way that I'm perfectly happy with. It's physicists who need to say what needs to go into, what needs to be stored from each scan, and how a manufacturer might be encoding that. I think. Yes.
One last question. So just in terms of pipeline, like analysis pipeline, that are compatible with clusters, for example, do you have any suggestions? And I can mention that we lately looked at the next flow approach, which looks really cool, very useful. So I don't know what's your take on that.
So the question is about pipelining software. So a few years ago, probably the best you would hope for would be a bash script, maybe just a list of commands in a file that you would run. You'd lay out your data and then run this bash script, and it would do a whole bunch of things. You'd add things here and there, it would fiddle around with it. You could never reuse it because you'd written it for one study and then you couldn't read it 3 years later, or your PhD student had written it and then you had no idea what they'd done, and it was a bit of a mess. There's a family of tools now. Nextflow, Julian mentioned. I'm very fond of a tool called SnakeMake, which is a Python tool that actually came out from the genomics community, but is very applicable. NiPipe as well is a more neuro-specific tool. I really like them, is my answer to that. I say we're using SnakeMake now. That has very good facilities for using singularity containers. It will run on a laptop for development and then with the same commands run on a cluster, which is great. The steps you write in that are more modularizable. You can reuse those much more easily than you can a bash script. Nothing but good things to say about them, really, I think. SnakeMake, Nextflow, NiPipe. I don't have I have one I use, but you might prefer something else. There is something called Common Workflow Language that is an attempt, I think, to have a common standard or common core that allows these tools to communicate. I haven't looked at that very much, but it's out there, so theoretically your preference doesn't need to be everyone else's preference. But yes, if I had a sixth lesson, it would be try and use a tool like that rather than scripting. Yeah. Julian, any other questions?
Bowling,
right, okay. Good.
Maybe, and yeah, quite thankful to speak to the session and